a lot of fantastic material to cover this afternoon. If any of you have ever attended our Medicaid 101, it's like drinking from a fire hose. So it's more like about a 4,000 level college course. We try to keep it at a minimum, but you know Medicaid can become complex very quickly. We've got a panel of experts here that is going to assist us today. So if we could get some material on the big screen. There we go. There we go. So real quick introduction. I'm Matt Dole. I'm Chief Operations Officer at RTS Solutions, and I'm joined today here by my fellow presenters, Mr. Eric Kimmelblatt. He's the Senior Director of Managed Markets at RTIA. Ms. Helene Gregory. She's the Senior Director of Puerto Rico and U.S. Virgin Island Operations at RTIA. Ms. Kinsey Caldwell, she's the Senior Director of Analytics at RTIA. Mr. Brad Burris, Senior Director of Government Accounts at Pear Therapeutics. And joining us virtually will be Jorge Galva. He's the Executive Director of the Puerto Rico Health Insurance Administration. He'll be joining us later during the presentation. So real quick, a little housekeeping. We'll be using Slido for the question and answer session throughout today's session. At any point during the session, you can go to slido.com from your phone or for your laptop to enter in the event code hashtag Crossroads 2021. Then choose the Crossroads General Session Room. If you're joining us virtually today, Slido is embedded into your virtual platform, so you can type in your questions in the Q&A box and thereafter choose the Crossroads General Sessions room. You can enter in your questions anonymously without your name at any time. All right, let's begin. A few disclosures. No one in this panel has any actual or potential conflict of interest in relation to this presentation. Today's agenda, we're going to start out with Brad Burris. He's going to give you the pharma's perspective when it comes to Medicaid. It's going to be a nice little presentation for us. Then we're going to join into deep dive into Medicaid 101. We're going to talk a little bit about the background of the Medicaid program. We're going to go into pretty deep, in-depth about pharmaceutical management inside of Medicaid. We're going to talk a little bit about managed Medicaid, a little bit about Puerto Rico, topic of drug reimbursement, and then we're going to end it on everybody's favorite subject, federal and supplemental rebate calculations, where Kinsey's going to walk us through all the mathematic calculations for the federal and supplemental rebates.
Save the best for last.
A little bit about today's schedule. Again, like I said, we're drinking through our fire hose today. We got a lot of material to cover. We're going to do our best to stay on schedule here. So right now, let me introduce Brad Burris. He's going to give you the pharma's perspective on Medicaid 101. We're going to jump in real quick.
Can you say real quick one more time? One more time. Thank you very much, and welcome to Crossroads 2021. I know we're all really excited about going to a conference finally. It's finally here. And reportedly, this is now the largest Medicaid meeting on earth. So there's 400 people here. It's dramatic. But thanks. Let me get right into it before Matt gets a little bit tachycardic on me. My piece is really just talking about the account manager side of this, not the implementation side. The building blocks are going to come later in the presentation, but really how do you put those together and you strategize and you focus on the needs of the customer? And that's really where we'll land. A couple bits of good news. I've got like 2 or 3 slides, and I probably won't even use them all. So we'll get right into it. Building the value for all stakeholders, that's the key. And this really is kind of focused for people that have forgotten stuff about Medicaid or new to Medicaid. I know there's a lot of experience in the room, so a lot of it will become common sense. But I'll share some perspectives on my experience and hopefully be able to help in some situations that are going to come up for you as well. But all the strategy, value props, the marketing, and all the analytics are not going to matter at all when you get in front of a pharmacy director. If you don't customize it, if you don't tailor it for what they're going through. You know, we get indoctrinated by our company and the training programs and all the analytics and strategies they want to put in place. But at the same time, if you don't go in front of a customer and say, hey, I understand your population, how it means something to you, what utilization management means to you in Vermont versus Alabama, they're all different. If you can't customize it, they don't care about your value prop. They don't care about your strategy or your analysis. So you have to make it very customizable and tailored to the needs of the person across the desk. And my experience in Medicaid, I kind of went into this kicking and screaming years ago. I didn't want to be the Medicaid guy. But once you understand what's on the other side of the table from you, it's incredible. It really is the last bastion of our healthcare industry that truly cares about the patient. Because the pharmacy director across the table, the medical director, the labor that they apply towards understanding the beneficiary the best, you don't see that in commercial. You don't see it in Med D anymore. They're talking adverse selection and over-indexing. This book of business puts the patient first always. So make it customizable and meet the needs of that pharmacy director. Now leap with me a little bit. I've got to take a leap here because I got some questions from the RT team. I'm like, where are you going with this honeybee thing? I raise bees at home. And the neat thing about bees, everybody's got their job. If the queen doesn't do something, it falls apart. The drones, the worker bees, honey does not get produced at the end. But we all have a stake in this. You're all stakeholders as well. Your companies think of the world of you. They have a lot of confidence in you because they give you the responsibility for Medicaid, and that's a big deal. But with honeybees, you have to be organized. You have to have a plan. You've got to be willing to course correct because nobody's right all the time. And surprisingly, you'll find more common ground than differences when you're working in this book of business. But you have to care for, respect, and aim to understand who you're talking with and what they're dealing with day to day. They don't have just one category. They've got 1,000. So they're trying to spin plates and jockey with that as well. Don't get stung because I can tell you from experience, NDC blocks hurt, step edits hurt, PAs, we can get through those. But just have a plan and go in it with less emotion than what you think you have to have. Have a business-minded approach and everything will be okay. Never underestimate. Sometimes these problems look unsolvable, but you'll work with smart people, committed people that will solve problems for you, that really will help you implement and be a shining star at your company. And aligning the synergies, I think this is the common sense part. You have to build value. You have to show that you're a resource every single time you get in front of a pharmacy director. Make sure that they understand that you thought this through. You're giving them options like the value-based option. It's not just value-based. Now there's Netflix and subscriptions, and maybe it's just straight supplemental where you work with RT and you don't even need to do a rebating program. But have those things thought out and discussed prior to going in before a meeting with a pharmacy director. And it can't be episodic. Make sure you challenge yourself to be a resource every single time. Putting the patient first is something discussed. The resource value, that's every time. And understand both sides have incentives and disincentives because sometimes paying based upon cost just begets more cost. Make it speedy and decisive and offer solutions. And I think everything's going to be okay. And with that, I thank you for your time and attention. Turn off the news. Love your neighbor. Thank you.
All right, thank you, Brad. If you have any questions for Brad, again, feel free to use the Slido app, hashtag Crossroads 2021, and they'll let us know when you submit questions, and we'll do our best to answer. We've got a lot of brain power on the panel here, so we'll get started. Let's talk a little bit about Medicaid background, give you some background on the Medicaid program and how it started. So Medicaid, it was established in 1965, actually. Part of the Lyndon B. Johnson administration as part of the implementation of the Great Society. Medicaid program is authorized under Title 19 of the Social Security Act. So if you ever want some fun reading, go out there to the Social Security Act. You can read all you want about Medicaid. But what we're going to try to do today is cover enough material where maybe you don't have to go read so much. Medicaid program, it's also an entitlement program, which means that if you qualify for Medicaid as an individual, you are entitled to receive the services that the Medicaid program is provided. States cannot limit their eligibility in Medicaid for qualified individuals that cover, i.e. meaning they can't cap enrollment. Now we'll talk about some ways that states use waivers and things like that here a little bit later on. The program is jointly funded. Many people don't realize this. It's jointly funded between the state and the federal government. And that funding comes down and is allocated to the states through what's called the FMAP, or the Federal Medicaid Assistance Percentage. This is a calculation that is done at the federal level that determines the amount of federal funds and state funds that are used to pay for the Medicaid program in each state, and it's all on an individual state basis. Medicaid program is administered directly by each state. Each state is responsible for administering its own program. And that plan of administering that program is documented in what's called the Medicaid State Plan. The Medicaid State Plan is basically an agreement that's documented as between the state and the federal government, describing how a state administers its Medicaid program. A little bit about Medicaid that maybe you didn't know. So a little bit before pre-COVID-19, talk a little bit about that. So did you know that before COVID-19, there was about 75 million individuals on Medicaid, which is about 1 in 5 Americans. And that about half, or over 46% of the individuals on Medicaid are children. A lot of people don't realize that. It's mostly made up of children. Did you know that about half of all births in the United States are covered by Medicaid or financed by Medicaid? And in 2018, roughly $600 billion were spent on the Medicaid program, of which about 62% were federal funds, about 38% were state funds. And today, that spending is well over $600 billion a year. Did you know that Medicaid accounts for 1 in every 6 healthcare dollars that are spent in the United States today? It also covers about 50% of all long-term care spending, such as nursing home and community-based care. It also accounts for about 10% of the overall prescription drug spending in the United States. Medicaid program is also what we call a counter-cyclical program. When we talk about Medicaid enrollment, when the economy does well, the Medicaid enrollment and spending typically either goes flat or is on a downward trend. Conversely, if the economy takes a downward turn, Medicaid enrollment typically increases and expenditures increase. So this always puts a strain on states' budget, because as the economy goes down, state and federal revenues tend to go down with it, but enrollment in Medicaid tends to go up. Let's fast forward to Medicaid today. So before that, let's talk a little bit about pre-COVID. Now let's go to Medicaid. What do we look like today? There's about 83 million lives currently covered in Medicaid. That's about 11% change since March of 2020, since COVID hit. So quite an increase in 1 year, just over a little over a year now. That's about a 43% change in enrollment since the Affordable Care Act was passed in 2010. So Medicaid has been, by and large, on an upward trend since 2010. Did you know that CMS sets the guidelines for states? So as I mentioned, the Medicaid program is a federal and state partnership, but basically the federal government makes all the rules under Title 19 of the Social Security Act, and CMS sets those guidelines requiring the states to implement their programs statewide. They can't implement Medicaid program in half of their state. They have to implement the program statewide. They have to provide comparable benefits to comparable enrollees. States have to ensure freedom of choice of providers for recipients. They have to have some choice in providers. You cannot restrict them. They require states to cover what are called mandatory services, and we'll talk a little more about mandatory and optional services here in just a minute. And then our states are also required to cover what are called mandatory populations. Now, states have a little bit of flexibility in that they are allowed to be flexible in eligibility standards, mostly income levels and certain eligibles that they can cover. They have a little bit of flexibility in their benefits package, which you'll see between their mandatory and optional benefits that they're allowed to cover. They have flexibility in what they pay their providers. So many of you that contact us, you may have some providers screaming about underpayment. So there's some flexibility there for states. They have flexibility in how they administer their program. Again, that Medicaid state plan is kind of the playbook for each state on how they administer a program, and then how they certify their providers to participate in Medicaid. As I mentioned, Medicaid, 54-year-old program. Enrollment continues to grow, and its benefit structure and drug coverage continues to evolve. Medicaid generally provides coverage to low-income people under the age of 65, children, pregnant women, low-income elderly people, and people with disabilities. Medicaid program, states are allowed to cover their beneficiaries either through two different service options, either through Medicaid fee-for-service or Medicaid managed care. We'll talk a little bit more about that here in just a minute. Now, I know I skipped the two in the middle, but we're going to go over those two here on the next slide. But many of you are probably familiar with dealing with Medicaid fee-for-service or Medicaid managed care programs. If you don't understand the definition of Medicaid fee-for-service, this is exactly how you state it, in that a recipient goes in, maybe sees a doctor, receives a service from that doctor bills the Medicaid program and receives a fee from the Medicaid program in exchange for that service. And that fee is paid directly by that state to that doctor. In the sense a beneficiary is enrolled in a managed Medicaid plan, that managed Medicaid plan is contracted with the state. It receives a monthly capitated payment from the state, and in exchange for that, that managed Medicaid plan is required to cover all benefits and services for that recipient. We're going to cover Medicaid managed care in depth here in just a few minutes. But before the Affordable Care Act, we'll talk a little bit about what Medicaid eligibility looked like. So before the Affordable Care Act, Medicaid program focused primarily on covering children under the age of 18, pregnant women, disabled individuals that received Social Security income. Also, many of the programs covered the parents of those children that were covered. But as you can see, I know that probably have to look at your book. Writing tends to be a little bit small on the screen here. But for the parents, typically across the country, what you would see is those with income, those who had income coming in, to qualify as a parent, your income could be no greater than 61% of the federal poverty level. To give you an idea what the federal poverty level is for an individual in 2021, it's about $13,000 a year. 61% of that would qualify you on the medium across all the states if you are a parent of one of these children in a Medicaid program. Again, this is pre-Affordable Care Act Medicaid coverage. But then those without income coming in, their qualification was about 37% of the federal poverty level. Some Medicaid programs before the Affordable Care Act passed in 2010 actually did cover childless adults. In states, there was about 9 states that covered childless adults at that point in time, and these all had to be conducted through a waiver that these states received in order to expand their Medicaid program to childless adults. So prior to the Affordable Care Act, states pretty much just covered children, pregnant women, disabled individuals, and with pretty severe, strict income requirements. Now let's look at post-Affordable Care Act. Affordable Care Act allowed the states to expand Medicaid eligibility to a group of adults with incomes up to 138% of the federal poverty level. This new adult group consists of individuals under the age of 65 with incomes below 138 of federal poverty level who were not pregnant, because they already cover the pregnant women in there up to 185% federal poverty level. Those who were not entitled or enrolled in Medicare Part A, and those that were not in any other mandatory Medicaid eligibility group, such as children under 18, disabled individuals. I've heard a lot about Medicaid expansion over the last few years since the Affordable Care Act. About 39 states to date have expanded their Medicaid program to include this new adult group, this childless adult group. There's about 12 states that still have not expanded their Medicaid program or are still waiting to adopt. This is a good depiction of Medicaid enrollment over time. It's pretty small on your screen, but if you could follow along in your books. So all the way back to 1965, you can see Medicaid has grown up to 83 million individuals. We are now at about 1 in 4 of Americans in the United States that are on the Medicaid program today. And there was a lot of talk in our earlier discussion today in the question and answer about what's going to happen with Medicaid eligibility once the emergency is lifted for COVID-19. So we'll see what happens with that. But this also is a good depiction of how Medicaid is cyclical or counter-cyclical in that, you know, during the early 1990s, you had the Medicaid expansion there and on the highlighted there on the left of pregnant women. So you can see an uptick in enrollment there. And then you had some welfare reform that came around in the mid to late 1990s, and Medicaid enrollment went down as a result of Medicaid or as a result of welfare reform. Then you saw a little downturn in the economy from 2000 to 2003, followed by the housing bubble, or the housing increase there from around 2003 to about 2008. Economy was doing very well, so you can see how that growth line flattens out a little bit. And then the housing bubble burst. And coinciding with that burst is an increase in Medicaid enrollment. And then also, shortly thereafter was the passage of the Affordable Care Act in 2010, and you can see Medicaid enrollment has been growing steadily ever since, with a large peak there due to COVID-19 since 2020. As mentioned before, the Medicaid program is composed of what are called mandatory and optional benefits. Mandatory benefits are a list of benefits that states are required to offer recipients, and these include things such as hospital inpatient and outpatient services, laboratory and x-ray, physician services, and even Medicaid transportation to get individuals back and forth to their appointments. On the other side of the ledger, Medicaid, there is a litany of optional benefits, and a lot of folks who have never attended the Medicaid 101 class did not realize that prescription drugs are actually an optional Medicaid benefit to states under federal law. And however, every single state in the country that operates a Medicaid program includes prescription drugs in their benefit. So very interesting. I won't go through all the optional benefits, but it is quite a substantial list. The interesting thing about this is that when I talk about Medicaid flexibility for states, is that typically states have the most flexibility in establishing their benefit packages or restricting their benefit packages or changing their benefit packages to those optional benefit groups. They typically have a lot less flexibility because, again, under federal rules, to do anything with those mandatory benefits. And as you can see there are probably a lot of expensive line items there, hospital inpatient, outpatient services, a lot of very, very expensive pieces under mandatory benefits that states really can't control. So when you hear about states trying to change their Medicaid benefit structure, it's typically on one of those items on the right-hand side. That's why we see, and we're going to cover this in a minute, so many restrictions and so many utilization management opportunities for states on the prescribed drugs, because it's probably about the highest spending item on that optional benefits side. As I mentioned a lot about Medicaid flexibility, well, if a Medicaid program wants to do any changes, construct any changes, or try to do business in a different way, they must apply what's called a waiver. Okay, and these waivers give states the flexibility to maybe change a benefit package to a certain group of individuals. The state has to apply for the waiver for the federal government to waive certain sections in federal statute, Title 19. They want to waive those sections in order to give them that flexibility. Maybe they want to include individuals or operate a managed Medicaid program, place individuals under managed care. States actually have to get a waiver for that in order to operate managed care in their states. What you're looking at here are about the four most popular waiver types that states use in order to get that flexibility from the states. You have Section 1915 A and B waivers. These are what we call the managed care waivers. 1915A waiver is basically allowing a state to operate managed care in their state, but it has to be voluntary. Recipients get to choose whether or not they want to be in fee-for-service or managed care in that type of a waiver scenario. Most states have now gone to the 1915B waiver, where they're mandatorily assigning recipients into managed care if they do not make a choice. So they have to have that authority. Then the Section 1915C is your home and community-based services waiver. This is mostly used for long-term care, elderly individuals trying to provide services in their home, keep them out of the institutional care. And then you have the waiver that provides the states the most latitude, but probably the most difficult waiver for a state to get, and that's called 1115 waiver. These are the waivers that states go after when they want to do things like block grants. There was a question in our earlier session about TennCare and their block grant proposal. These would be done under an 1115 waiver. This gives the states the most flexibility, but they also have to provide some guarantees. They also have to have some restrictions on their spending as they enter into these things, such as the program has to operate at a budget neutral position over what they would have spent if they did not get the waiver, things like that. We won't go into a lot of detail on that. But for flexibility's sake, the states have to use waivers to conduct this, and most every state has a waiver. I used to show a list of states with their waivers, but basically every state has some kind of waiver of some shape or form, especially those that operate managed care. So with that, that's going to be our background on the Medicaid program so far. We're going to take a break for about 5 minutes, but before we do that, I'm going to look in the back to our guys operating Slido. Do we have any questions that have come in? All right, looks like we do have a question that's come in. So it says okay, on my screen now. So has the average length of time on Medicaid been measured, and are there any limits to coverage in the commercial world once on Medicaid? Well, that's a great question. I know that I don't have the exact number, but I want to say the last time that we looked at this, Eric, probably about 9 months individuals are on Medicaid.
Yeah, it's somewhere between 9 and 12 months, and it's not a one-time thing. It can be cycling in, cycling out, going back into commercial if they get a job. They could be going to the ACA. So there's a lot of dynamics in it, but I think, Matt, you're right, where we typically see an average somewhere of a year or less.
Yep. Yeah. About 25% of the Medicaid population is under what we call churn, Medicaid churn. They churn in and out, come in and out of the program every couple of months. So states constantly are having to deal with that churn. Any other questions?
The limits to coverage in the commercial space. There's that question about
yeah, there was
limits to
a
coverage
comment
in the
in the
commercial
question
space.
about, is there a limitation on coverage if you are on Medicaid? I think the question is if you've been on Medicaid, can you go out of Medicaid and get commercial coverage?
Oh.
Yes, you can, and that does not limit you on what type of commercial coverage you can get. You just shouldn't or cannot get it at the same time.
I think the rule of thumb when it comes to Medicaid and dealing with commercial or any third party is that Medicaid is always the payer of last resort. Medicaid is always going to look to bill other third party, going to research that recipient's coverage to find out if they can bill somewhere else before Medicaid pays. That's the biggest rule of thumb. Next question. For 1115 waiver for budget neutrality, what is the time frame? It's typically those waivers are typically a 5-year time frame. Those waivers are granted typically for 5 years. States can negotiate that budget neutrality. Again, it's a very complex process. That's basically a personal dealing between the state and the federal government on how they're going to do that. It can be measured over the 5-year period. And I think at one point in time when I was in Florida and we did our first 1115 waiver, it was actually looked at on a year-to-year basis during that 5 years as well. So I think we're going to stop there, go ahead and take our break. I know we got a lot of material to cover. Take a quick break, be back in about 5 minutes. And we'll get back started.
5 minutes sharp.
Yep, we're going to do 5 minutes sharp. So we'll get back to it. I'm going to go into the details. As always, we try to structure Medicaid 101 more geared to the pharmaceutical industry and the drug benefits. So we're going to start going into details about pharmaceutical management in the Medicaid program. I'm going to specifically talk about fee-for-service right now, and then Eric's going to come on and talk about managed care. So before we talk about the details of the benefit, we need to make sure we understand who we are talking about. A lot of you that deal with us understand the terminology controlled pharmacy lives. As I mentioned on previous slides, we had 83 million, or we have 83 million individuals enrolled in the Medicaid program today. One of the questions that you always ask yourself is, where are those lives located? Where are they receiving their medical benefits from? And if you look at how those lives are currently distributed across Medicaid, you can see they receive their medical services. About 74% of those 83 million lives are actually enrolled in some kind of Medicaid managed care program, and about 25% of those individuals are enrolled in Medicaid fee-for-service. Now, this is very interesting, though, from a drug industry standpoint. You need to be very careful when you're talking about your lives, because just because someone is enrolled in a Medicaid managed care program, Medicaid managed care program may not be the program that is actually managing that drug benefit. And so what we do here at Artia Solutions is we convert those lives over to what we call state-controlled pharmacy lives. State-controlled pharmacy lives are those lives where the state is actually controlling that pharmacy benefit. And you're gonna hear a lot of talk about single preferred drug lists, about Medicaid pharmacy benefit carve-outs. You're going to hear a lot about that here shortly. Essentially, there are a lot of states now today, 21 of them actually, that operate what are called single preferred drug lists, where the state is the sole decision maker on the coverage criteria for those drugs on that preferred drug list, and they are dictating to the managed care plans in those states that they have to follow that exact preferred drug list that they develop. So what we do, we account for all of that. And when we do, it becomes a pretty large shift in who is actually controlling a benefit. So as a pharmaceutical industry, you want to know who's controlling that drug benefit. And essentially, it reverses the coverage. We ended up with about 66% of all the Medicaid lives have their pharmacy benefit controlled by the state. Now, this is going to get very interesting in the next couple of years, because we've got the states of California, very large state, that is not included in these numbers. And we have New York that are going to come on, very large Medicaid programs. Both of them are going to operate a pharmacy benefit carve-out, where we're going to basically take the pharmacy benefit away from the managed care programs, and they're going to be operated solely in the fee-for-service program. That's going to cause that blue line to get even bigger on this chart. We're going to see something in upwards of 80-some-odd% of all the Medicaid lives, pharmacy benefit, being controlled by the states across this country. As I mentioned before, coverage of drug under the Medicaid program, it is a optional benefit for the states. And states have to follow Section 1927. As I mentioned, Title 19 is the sole governance and federal law of the Medicaid program. Section 1927 is the drug benefit. If you're in the pharmaceutical industry, that is a good section of the law to completely understand. We're going to go through it line by line here in just a minute. No, I'm just kidding. I'm just kidding. I'm not going to do that. I wouldn't do that to you guys. We save that. We let Kinsey, we let her go through all that good stuff. But essentially, in Section 1927, it defines what is considered a covered outpatient drug. That is a definition that you need to be familiar with from the pharmaceutical industry, is that if you're a covered outpatient drug, which includes any kind of infused or injected drug provided in what's called an outpatient setting, i.e. meaning there is some kind of direct payment to the provider for that drug, either a buy and bill, where the state or the managed care program is paying that provider directly, or maybe it's a retail community pharmacy where the pharmacy is billing the state or the managed care program, and there's a direct payment specifically for that drug. Those types of drugs meet that definition of covered outpatient drug, and you as a pharmaceutical manufacturer are going to be liable to pay a Medicaid rebate on that utilization of that drug if your drug falls in that definition. There are some drugs that fall out of that definition, and these are drugs that get paid for as part of a bundled payment arrangement, like, for example, drugs used in a hospital inpatient setting that are paid for under a DRG, a diagnosis-related group, which is an all-inclusive bundled payment. Those do not meet the definition of covered outpatient drug under Section 1927. Therefore, there is no rebate liability associated with that type of drug. So need to be familiar with those definitions in the pharmaceutical industry. When we look at the coverage of drug under Medicaid, coverage rules may differ in the state by age of the beneficiary. Beneficiaries under the age of 18 are entitled in Medicaid to receive all medically necessary services. I'm sorry, under 21, having a hard time reading my slide here. But under 21, they're entitled to all medically necessary services. States have a difficult time restricting what I call access to these drugs. They cannot deny coverage for drugs for individuals under 21. Adults can be subject to prescription limits. So there's a lot of broad things that states can do, and we're going to go into a lot of details on some of the real specific things, but some of the things that have to do with coverage in Medicaid. So when we talk about drugs or pharmaceuticals in the Medicaid program and we go into pharmaceutical management, the question is why? Why is it so heavily managed? Well, one, it's an optional benefit, like I mentioned earlier. You know, there's more freedom to the states to operate or define the benefit, create a new benefit design. Two, it's a very extremely visible benefit. A lot of high-cost drugs, a lot of life-saving drugs, a lot of things that go on that bring visibility to prescription drugs. And I think we see that across the country and on almost every plan. Prescription drugs are relatively easy to analyze. Expenditure growth, savings opportunities. States have legacy electronic claim systems that they use to pay the claims, pay pharmacies for the drugs, and these are very complex systems that integrate drug utilization review drug utilization review edits, and then these systems can be programmed for prior authorizations, et cetera, for coverage to help states direct coverage to certain products. And then you also have multiple experts across the country that assist these Medicaid programs, such as Magellan Medicaid Administration, Change Healthcare, OptumRx. These are all vendors that are contracted directly with these states that's sole purpose is to help them manage their drug benefit. State Medicaid programs use multiple strategies to manage drug utilization. So what exactly is drug utilization management? Essentially, what it is they take the opportunity to place certain access restrictions on drugs to try to move utilization from high-cost drugs to lower-cost, equally clinically effective agents. That is their goal. And they do this through the formulation of either formularies or preferred drug lists. The term formulary is going to be used most widely when you're talking about a managed care plan, if you're dealing directly with them. States, by and large, use preferred drug lists. That is a nomenclature developed actually by the state of Florida, George Kitchens, whenever he developed the preferred drug list in Florida. Preferred drug lists are used to manage drugs where you have products that are considered preferred or non-preferred. We'll talk a little bit more in depth on that here in a minute. Some utilization strategies that states use as well are generic drug requirements. Many states have generic substitution laws where if a brand name agent is prescribed, that agent is allowed to be switched at the pharmacy. There's no prior authorization, no call to the doctor that's required. They're allowed to automatically switch. However, you will find in the Medicaid program that there are a lot of brand name agents that are considered preferred over their generic counterparts. And this is because of the unique situation with Medicaid rebates where there are many legacy brand name drugs that are actually less expensive than their generic counterparts. So from a state standpoint, they're trying to be diligent with their taxpayer dollars. They're going to utilize the lowest cost option, especially if the brand name drug is less expensive. Then here recently, what we've seen states do is pass legislation that is termed high-cost drug legislation. And I have affectionately named these the name and shame legislative priorities or legislative issues that the states have passed. States like the state of New York and Massachusetts, if you are a drug that falls into what they call their high-cost drug legislation, you may be identified by them, and they're going to ask you as a pharmaceutical manufacturer to pay an additional rebate above and beyond your Medicaid rebate that Kenzie's going to talk about here in a few minutes. But they want you to pay a supplemental rebate, and if you choose or fail to negotiate with them, they're going to put you in front of a public committee and ask you to testify. Of course, you can take the fifth if you want, but you can testify on how you came up with the cost of your drug to that committee, i.e., the term, I labeled it, name and shame. There are also some states that are passing what are called drug review boards. This is where the state have appointed a council or a group of individuals, and their sole responsibility is to review these high-cost drugs that have come to market. And during their review, they're going to make recommendations to that state, either of reimbursement, how the state should reimburse or the amount they should reimburse for that drug, or recommend what the actual cost should be for that drug. So some very interesting dynamics. These are the most recent utilization management type strategies that are coming down from the states. But by far, the most popular are going to be your prior authorization or your step therapy or your quantity limits that states put in place. And prior authorization basically means if you want an agent, certain specific agent, the state is going to require the doctor to complete specific paperwork to either document why that drug is medically necessary for the individual, i.e., seek prior authorization before he can dispense. Or states will implement step therapy, where recipient has had to have documented a trial or failure of another agent prior to receiving the agent of choice. And then states implement quantity limits. For example, I believe, good examples, like Alabama, I believe, has a 5 brand name drug limit right now for recipients. So all of these are various utilization management techniques. All of these can be incorporated into preferred drug lists. By and large, the largest utilization management technique across the country, Florida enacted the first one in 2001. Today, there's about 47 states that operate preferred drug lists across the country. There are a handful of states that do not have PDLs. The states that operate preferred drug lists, they review about 50 to 60 categories, therapeutic categories a year. And they do these through P&T committees. These P&T committees usually meet around 2 to 4 times a year, where they, during these meetings, they go through various therapeutic classes. The dynamic of the PDL is that as a state moves further along into the development of their PDL, the PDL generally becomes more restrictive, or they add new classes. So it's always dynamic. The state is always seeking a way to do utilization management on their drug spend. The PDL decision establishes a product as preferred or non-preferred on the PDL. If a product is non-preferred, it generally requires the prior authorization, which means it has to demonstrate that there has been a failure of a preferred agent, or some kind of documentation has to be completed by the provider to explain why the preferred agent is not medically necessary to be used. Drug classes on the PDLs are generally reviewed once a year. As a state reviews drug class, they do it based on clinical and financial merit. Supplemental rebates become involved and are leveraged to influence these PDL decisions on who's preferred, which drugs are non-preferred. Some states during their P&T and PDL meetings, they have open discussions. Others have closed-door discussions, or what they call executive sessions. And most states announce their PDL decisions at the end of their meetings. So what is the PDL, or preferred drug list, impact on products? So if your product is subject to preferred drug list review and the product becomes preferred, which is a good place to be, it typically means that there's unrestricted prescribing that is allowed for that drug. So that drug is, the doctors have the ability to prescribe that agent free and clear without any prior authorization. That product probably has some kind of supreme clinical advantage over other products in the class, especially if it's a large class with multiple products that are available. Or maybe the product's net cost, which you're going to learn about here in a few minutes, is advantageous to the state, meaning it's less expensive than other agents in the class, usually either from high Medicaid federal rebates or statutory rebates that they're also known as, or maybe a combination of those and supplemental rebates. Sometimes states require clinical prior authorization for preferred drugs. We know that prior authorization is typically always required for non-preferred drugs, but sometimes they place those clinical prior authorization on preferred agents as well. But when they do that, it's typically the same across all the drugs in that class, i.e. meaning that drugs, even though there's a clinical prior authorization on the class, are typically not advantaged or disadvantaged to each other. Non-preferred drugs typically require a failure of one preferred drug. Again, that depends on state policy. Some classes may require failure on 2 preferred drugs, some 3. I've seen some states that are very restrictive that have classes and drugs up to 5 failures. So at the end of the day, when you're dealing with a preferred drug list, your product is either going to be preferred or non-preferred on that PDL. And the preferred position is always the most advantageous. One last thing to talk about when it comes to PDL impact is copays. A lot of folks ask a question about copays and how they affect prescribing habits, how they affect recipients' behavior, and that. In Medicaid, copays really don't guide recipient behavior in the Medicaid program because a prescriber is typically not allowed, or let me rephrase this, a pharmacy is required to dispense that agent even if that recipient has failure to pay the copay. So the recipient is still going to get that drug. So when states are analyzing the pharmaceuticals, they typically don't look too much at copays. What are some of the things that influence the decision of a drug to be preferred? Well, could have a supreme clinical advantage. That's certainly one thing that's going to influence the state's decision to make a drug preferred. Or it's going to have a net cost advantage. Net cost, which you're going to hear about in a few minutes, is pharmacy reimbursement minus all rebates, the federal or the supplemental rebate. A drug might have excellent market share. That's also going to be something that's considered. The drug also may have the ability to move market share. That's something else that's going to be considered heavily if a drug is trying to make, or if a state is trying to make a decision to make a drug preferred. Where that drug is in its life cycle, is the drug getting close to losing its exclusivity? Is the drug about to receive any new type of indication which is going to increase its potential use? Generics, are there any generics available for that same agent? You know, generics may not always be the less expensive option. Many, in the Medicaid program, many legacy brand name drugs are the least expensive option in the class. And then the PDL vendors, the Magellans, Change Healthcare, certainly have some influence over which drugs are preferred. State pharmacy directors, obviously, as well. And then whether or not you're working with a purchasing pool. Big decisions there on which products are preferred. When it comes to pharmaceutical management in the states, this is probably one of my favorite slides that depicts how well these utilization management techniques work. So I took this snapshot out of the Medicaid, or Magellan Medicaid 2017 Medicaid Trend Report. This is 1 year's worth of data. Really what I want you to pay attention on this slide is the blue line and the green line. Just notice that they are flat. These are, Magellan Medicaid manages about 25 states, and this comes from a report that they publish every year. And basically what they were able to do is to demonstrate that they had held the net cost of all these agents basically flat over that year period, no increases. That's how effective these utilization management techniques combined with rebates, preferred drug lists are. Holds the price down to the states. When you're dealing with preferred drug lists across the country, especially from a pharmaceutical manufacturer standpoint, you want to know who are the players. Who are you dealing with across the states? And certainly these vendors are a big gorilla in the room when you're dealing with these. There's 4 vendors that encompass 42 states and 46.8 million lives, or 86% of those state-controlled pharmacy lives that I mentioned before. So these are big players. The largest of which is Magellan. They encompass 25 states. They have 33.4 million lives. So as you as a pharmaceutical manufacturer, you want to make sure you know Magellan really well. They have about 61% of all of those lives. Change Healthcare has 13 states, 10.3 million lives, and encompasses about 19% of those total controlled lives. And then you have Optum RX with 3 states, 2.1 million lives, or 4%. Conduit, rounding it out with 1 state, which is the state of Missouri, about 1 million lives and 2%. All of the other states are what we call independent, or they don't have a PDL. As I mentioned, there are 4 states out there that don't have a PDL, as on the previous slide. But the remaining states are going to be independent states, and they're operating their own program, operating their own preferred drug list, such as one I think we have here today, I think Illinois. They operate their own program, do a very good job of it. They don't have the vendor. Medicaid purchasing pools, you hear a lot about that with pharmaceutical management, if you're in the pharma industry. There are 3 purchasing pools across the country, account for 32 states and 28.2 million lives. 34% of all the lives in Medicaid programs across the country are in these purchasing pools. The unique thing about the purchasing pool is negotiating supplemental rebates. That is what they're there to do, is to leverage their number of lives in order to negotiate better rebates for those states. Encompassing about 13 states is the Sovereign State Drug Consortium. They got about 10.3 million lives. The second one, National Medicaid Pooling Initiative, or NMPI, they have 12 states. Recently, the state of Virginia joined that July 1st. And then you have the TOPS program, the Optimal PDL Solution, about 6.9 million lives. Again, as I mentioned, these pools are unique in that they're leveraging supplemental rebates. If you are a pharmaceutical manufacturer and you offer a supplemental rebate to one of these pools, just be prepared that that supplemental rebate is going to go out and be seen by every single state in that pool. And if any one of those states within that pool decides to access that supplemental rebate, you owe it then to that state. It's not all-encompassing, but it is each state's choice to choose that. So you submit one rebate, each state has the opportunity to choose whether or not they take that rebate. Now, pharmaceutical manufacturers may have a rebate strategy where they offer an aggressive rebate in one pool and a less aggressive rebate in another pool, et cetera, but that's your strategy. But just know that when you offer that rebate, each state individually gets the opportunity to take that rebate. When it comes to contracting, the NMPI pool operates on a 3-year contract. The SSDC and the TOPS pool operates on 1-year contracts. A little bit about new drugs and the dynamics of preferred drug lists. We do a lot of new drug launches at RTO. And many times these drugs are already in classes that are reviewed as part of the PDL. And when that occurs, if you're a new drug launching in a class that's already reviewed as part of the PDL, that drug is typically, when it hits the market, it's going to require some kind of prior authorization or it's going to be non-preferred. Some states, for a new drug, may not even cover the drug right out of the gate whenever you launch your drug, as you learn from our market access team. They won't cover it until they complete their internal review, or maybe the state has specific paperwork that has to be completed. And you'll hear a lot about that in one of our sessions tomorrow on market access. When it comes to P&T reviews of your new drug that is currently in a PDL reviewed class, that state might review your drug as a single product review at the very next P&T where it's available to be agended, or they may make you wait until that class comes up for review. It just depends on the state. Each state has its own rules. What about a drug that is launched in a class that may not actually be on the PDL? States, as I mentioned, they may have 40 to 50 to 60 therapeutic classes. That certainly doesn't encompass every single drug class that's out there. So there are many times when a lot of these orphan drugs are not reviewed as part of the PDL. What happens to them? Well, when you look at it just kind of in general across the board, they may or may not require prior authorization at launch. Just depends. Each state is different. Some states may not cover. Again, they may not cover it until they finish their internal review or you complete some specific paperwork. Most states will do some kind of internal review of these non-PDL reviewed drugs, and that's when they're going to establish coverage criteria. They're going to develop clinical prior authorization or medically necessary prior authorization, or maybe even establish quantity limits and set reimbursement. So it's always good if you are a manufacturer and you're launching a drug that's not in a PDL reviewed class to have that relationship with that state. New to market drugs is kind of a little bit of a depiction. RTS Solutions, we specialize in market access for new drugs. This is just kind of a general overview of what to expect. There's a lot more detail that goes into this, but again, we're talking about 101 here. But generally, week one, as a new drug hitting the market, you're going to get your FDA approval. You're going to make sure that you have your CMS Medicaid National Drug Rebate Agreement in place, which is going to subject you to paying that federal rebate. You're going to make sure you get your drug in pricing compendia. Sometime between then and week 4, the state may begin their internal review or may begin to schedule your drug as part of one of your P&T or DUR board reviews. So manufacturer is always good when you launch a new drug to monitor for all of these reviews. And all of this process could take up to 6 months. It just depends on the state. They're all different. I mentioned before when I started off with the chart about single PDLs and carve-outs. And if you were here at the meet and greet section, we had a question about these. Recent phenomenon from a state's standpoint, recent decisions that states have conducted in managing their programs is to implement these single PDLs and carve-outs. Again, the question is, who controls the drug's PDL coverage status and criteria? What's the definition of a single PDL, also known as a statewide PDL, a unified PDL, etc.? There's about 21 states to date that operate one of these types of preferred drug lists. And basically what it means is that all managed Medicaid plans must use the same preferred drug list that Medicaid fee-for-service in that state operates. That PDL and that managed Medicaid plan has to mirror that state. The interesting part about this is that the managed Medicaid plans still process their own claims. They still process the pharmacy claims. They're paying their providers, et cetera. They're essentially just having to abide by that PDL document from the state. Under that situation, if you have a recipient that's in fee-for-service is processing their own claims as well. So everybody's still operating everything the same from a systematic standpoint, paying providers, processing claims, but they're all prescribing based off of one single PDL. Then we have carve-outs. We have 2 different types of carve-outs that you typically deal with, depending on your drug and depending on your manufacturer. But for the most part, the one that you can be sure of is in 5 states that have what we call full pharmacy benefit carve-outs. This is where the state has chosen to carve out the entire pharmacy benefit away from the managed Medicaid plans. Managed Medicaid plans no longer have any responsibility at all for the pharmacy benefit in one of these 5 states, which means they do not process claims. They do not pay providers. This is all now done through fee-for-service. And so you can see those 5 states right there in yellow. Then you might be fortunate enough to have a drug that is part of what we call select drug or drug class carve-outs. There are some states that choose to pick certain drugs or drug classes and take it away from the managed care responsibility and solely operate that as a drug benefit carve-out for that particular drug, and all those claims for that particular drug or drug class is processed through fee-for-service. Again, under this scenario for that particular drug or drug class, the managed Medicaid plans have absolutely no responsibility in managing or processing that drug. As I mentioned, this has been a trend. As you can see, here's the timeline of states that have implemented single preferred drug lists or statewide PDLs since 2013. Again, 21 states have now implemented these single PDLs. We have heard some rumors, I can't substantiate them, but we have heard some rumors that even Nevada is considering one in the near future. The most recent one is the state of North Carolina, just came on in July 2021. Full pharmacy benefit carve-outs, as you can see, there were 5 states, and now we're expecting California and New York in the upcoming future. So I'm going to end this segment, or get close to ending this segment, back to this same chart. So now that you understand a little bit more about pharmaceutical management, that's why it's so important as a pharmaceutical manufacturer to understand who's controlling this pharmacy benefit. So I always come back to this slide. You might have 74% of all the lives in the Medicaid managed care programs, but when you start considering who's managing the pharmaceutical benefit, that could flip. And again, right now, about 66% of those lives are being controlled by the state using those single PDLs, all those utilization management techniques, and carve-outs. So I'm going to stop right there. We're going to talk a little bit about medical benefit here in just a moment. Do we have any questions on that segment, Greg? All right,
Hey,
question
Matt.
is, how do you,
Oh.
yes, go ahead.
I was going to say, we're getting a lot of questions, and we're really tight on time. So if we don't get to all the questions, we will do what we did last year and review all the questions, write up answers to them, and send them out to the group.
How are we doing on time?
We're right on time.
Okay, all right. All right. Let's, I think what we'll do is we'll take these questions and we can try to answer these at the very end. Can we do that, Greg? That way we can stay on time. We can come back to these. Yeah, so these are fairly easy to do. Can we flip back to the slides? There we go. Yeah. All right. So let's talk a little bit about medical benefit drugs. So we'll keep those questions in the queue, and we'll hit those either right at the next break or right at the end. So we're talking about medical benefit drugs. What I've got here is a difference between pharmacy dispensed and physician administered drugs. So pharmacy dispensed drugs are billed through point of sale service, and are paid based on the 11-digit NDC, whereas physician administered drugs uses HCPCS codes and are paid for using a physician fee schedule and on a different type of claim payment system. Preferred drug lists continue to grow for for pharmacy dispensed drugs. However, you do not see physician-administered drugs typically reviewed on PDLs as often, although that trend is slowly starting to change. With biological agents that are entering the market, states are starting to reconsider how they manage physician-administered drugs. So as I mentioned, we see more of those drugs on the PDL than we did in the past. When it comes to reimbursement of pharmacy dispensed drugs, reimbursement typically is based on an algorithm of WAC price or a NADAC, et cetera, whereas on a physician-administered side, that reimbursement is typically started at the Medicare rate. Now, it may have been a Medicare rate that was established 3 or 4 years ago, as many as you may have seen, But at some point in time, it was probably established at the Medicare rate or a derivative of that Medicare rate, or maybe even WAC on that side. If we look at Medicaid or medical benefit coverage policies between existing drugs and new drugs on the medical benefit side. When it comes to coverage of existing drugs and medical benefit, prior authorization may be required, but there's very limited published criteria. That's what we see a lot for medical benefit drugs. When a new drug hits the market from a coverage standpoint, there's typically an internal review that is done by the state. It may not be out in public. It may not go to a P&T or DUR. There may be limited published criteria associated with that new drug, and that goes in general for medical benefit drugs. A lot of times we don't see a lot of coverage requirement, published coverage criteria associated with those drugs. When it comes to PDL management of physician-administered drugs, again, for existing drugs that are out there, it differs by state, it differs by drug or drug class, or when the state's going to manage that PDL. Criteria is usually published if the state manages a physician-administered drug on their PDL. You usually have access to published criteria because that's out in the public. For new drugs, it's going to differ by every state that's physician-administered. It's going to differ by drug class. But if a state actually reviews that drug or drug class as part of the PDL, again, that drug, if it's a new drug on a physician-administered side, it's typically going to be non-preferred. The good thing is you're going to be able to find criteria. So anything really associated with a PDL, you can typically find criteria. But what happens is they typically have step edits in place or some kind of criteria that's fairly restrictive. Supplemental rebates can be involved in drugs that are under PDL management. I mentioned earlier about reimbursement. Again, reimbursement for physician-administered drugs are reimbursed using HCPCS codes. They're not reimbursed using NDCs, and they're reimbursed from a fee schedule. If you have a new drug that enters the market and it's a physician-administered drug, it probably doesn't have an established HCPCS code. You would have to use a miscellaneous code for a short period of time until you receive a HCPCS code. Just a summary of comparison of the typical drug coverage for medical pharmacy benefit agents versus medical benefit agents. When it comes to the coverage review process, a drug that's on the pharmacy benefit, that review process is standardized. It goes through P&Ts, DURs, PDLs. Drugs on the medical benefit, not so much, not necessarily standardized. Typically doesn't go through P&T, typically doesn't go through DUR. Sometimes it will, but most of the time it doesn't. There's typically no PDL involved for those medical benefit drugs. Is it transparent? Well, if a drug goes through P&T, it's transparent. P&Ts are public, DURs are public. Not so much on the medical benefit side. Those are typically done internally, again, unless that drug is on that PDL. Criteria is rarely published for medical benefit drugs, as I mentioned before. And when it comes to reimbursement, drugs on the pharmacy benefit, that reimbursement methodology is standardized, typically transparent. There's dedicated systems associated with it. And on the Medicaid or medical benefit side, there's typically fee schedules involved. Those are published for you to see. They are all-inclusive reimbursement. And there's sometimes delays in how they're updated. All right. So we're going to transition over to Medicaid managed care. And if we have some time after this segment, we'll hit some questions. Okay? All right, Eric.
All right, we're going to change tunes now. A little managed Medicaid. All right, so just to highlight the differences between fee-for-service and managed Medicaid, they're pretty black and white. One of the biggest ones is that everything in fee-for-service happens in the open. Public forums, P&T committees, DURs, access to the people. And on the managed Medicaid side, it's very different. Some actually have public meetings, but most of the time you find out the results afterwards when they get posted. And like Matt mentioned before, fee-for-service, you're paying strictly for the service. In managed Medicaid, it's a per member per month fee that the state is actually paying to the plan to administer all the benefits to the Medicaid beneficiaries. In both instances, technically all drugs are available. Utilization management can be used in both fee-for-service and managed Medicaid. But from what we see day in and day out, managed Medicaid tends to be a little bit more restrictive in their PA criteria or step edits for the non-formulary or non-preferred drugs. Not drastically different, but a little bit more restrictive. And one thing that's really important to understand is that you're paying a federal Medicaid rebate on all managed Medicaid utilization. That changed, and we'll go through that in a couple of minutes here, but it's really important to understand that. That payment is not going to the managed Medicaid plans, but it's going to the states, and it is coming from the drug manufacturer. You can do additional rebating to the managed care plans, mostly through their PBMs, if you choose to. That's voluntary, and that payment would be going to the managed Medicaid plan or through their PBM. So just to set the boundaries there. And I'm going to reiterate quickly about carve-outs, probably just from the other side, the managed care side. Single PDLs and carve-outs are very, very important to understand. Where does your drug fall in? The single PDL, again, the state controls the access to that drug or that class, but the managed Medicaid is still paying and reimbursing for that drug. Okay, like Matt said, they're just abiding by the state's access profile. In a carve-out, the state basically takes away the coverage profile or the access profile for the drug and the financial cost of the drug. So in the carve-out scenario, there is no responsibility for payment or coverage policy by the managed Medicaid plans. And Matt walked through a couple different examples. We can do that at the entire pharmacy benefit level, like we're seeing California and New York contemplate. You can do it at a drug class level or even at an individual drug level. Depends on how the state may want to handle that. But basically, when you talk about a carve-out, whatever is being carved out is typically being carved out of managed Medicaid and into the responsibility of the state. That's a general rule of thumb, but you always need to be looking at who's talking about carve-out and where it comes from. So if your drug is subject to a carve-out in a particular state, you should be focusing 100% of your efforts at the state fee-for-service level. Because again, they've carved it out of managed Medicaid and the state has complete responsibility for it, both coverage and cost. Okay, we're going to talk about a couple of things here, the evolution, a little bit of history of managed Medicaid, key concepts in today's market landscape, new drug coverage, what happens when a new drug gets launched in managed Medicaid, comparing it to what Matt talked about in fee-for-service, and we'll close on keys to working with the managed Medicaid plans. So prior to the ACA, or January of 2010, 80% of the lives were in fee-for-service, and it's a big change from today. So the focus of the Medicaid account manager or the government account managers was at the state, because that's where 80% of the lives were. And the structures were very different today. And there may have been some account managers focused on some of the key managed Medicaid plans with the bulk of the other 20% of the lives, but most of the focus was on one account, the fee-for-service account in each state. Also, managed Medicaid drug utilization was not eligible for Medicare or Medicaid rebates, and the plans basically controlled their own formularies. But again, there weren't a lot of managed Medicaid lives. Okay, but after the ACA went into place in January of 2010, there's that huge shift, and it was almost like an encouragement to move to the managed Medicaid model. And between then and now, it's almost a complete reversal where most of the lives, or 75% or so, are in managed Medicaid and 25% in fee-for-service. Also, the base Medicaid rebate increased, obviously, from 15.1 to 23.1%, and the managed Medicaid utilization became eligible for Medicaid rebates, and that's a huge one. And so those two things together really hit the manufacturers pretty hard financially and brought the managed Medicaid market into focus. So some of the things that changed are that instead of the Medicaid account managers having one account in one state, you may end up having a state that has 3 managed Medicaid plans, 5 or 10 or more managed Medicaid plans. So, and those managed Medicaid plans may fall under a commercial responsibility versus the government account manager. And every company that we work with looks at it a little bit differently. So there are about 260 managed Medicaid plans, and you need to identify and work with them efficiently and effectively. And we'll talk about how to do that. But basically, the managed Medicaid plans ended up implementing major restrictions on utilization because they weren't getting the rebates. The federal Medicaid rebate was going to the state, and it took a couple of years actually for that cycle to equalize and basically turn the managed Medicaid plans into more of a commercial type of account that happened to be comprised of Medicaid beneficiaries. The other thing that occurred is what we keep talking about here that's really important is the statewide PDL concept and the carve-outs. And Matt showed you that graph of, as the years go by, more and more states are implementing these statewide PDLs and also considering carve-outs. So a couple key concepts to what the landscape looks like today. About 61 million people covered by managed Medicaid plans. And that's, again, right around 75% of the total number of Medicaid enrollees. About 260 plans across 39 states. And I mentioned it before with the capitation rate, risk-based model per member per month fee. It's a way for the state to pay a fixed rate per person that is being covered by the managed Medicaid plans. And the state offloads that risk to the managed Medicaid plans. That contracted rate or per member per month fee is going to cover pharmacy benefit and medical benefit for those patients, unless there's a carve-out of the pharmacy benefit. So if you look at the rates, they look extremely low, especially for patients that may have high-cost drugs or high-cost disease management treatment costs. And they are low, but it's the insurance game. There's a big chunk of patients that probably never seek care and don't cost the plans any money. And then there's going to be the portion of patients that have a lot of expenditures that cost the plans a lot of money. And somewhere in between, the plans are profitable. If you look at their annual statements and annual reports, they're doing very well. In fact, over $300 billion per year is paid by the states to the managed Medicaid plans on an annual basis. And while there may be certain studies or groups that try to prove that the managed Medicaid model works better than fee-for-service, there's no definitive data out there that proves one way is better than the other as far as cost and outcomes, et cetera. But the fact is that $300 billion plus is paid each year from the states to those plans. The managed Medicaid plans are required by federal law to provide services that are equivalent or better to the state. So meaning managed Medicaid needs to be equivalent or better than fee-for-service as far as the services provided. They don't get real specific, and a lot of people ask questions, well, does that mean if the state's covering this drug that the managed Medicaid has to cover that drug? It doesn't get that black and white, and it's a very gray area, and from what we've seen, it's highly interpretable. And the managed Medicaid plans typically interpret that in their favor, where if they have drugs in a particular class that are medically appropriate and available to the patients, they don't have to be the exact same drugs with the exact same coverage profiles, unless it is a statewide PDL. The contracts between the states and the managed Medicaid plans are renegotiated periodically. Most of them are 3-year contracts with extra years that they can extend. We're seeing very few 1-year contracts or 2-year contracts just because of the effort and time involved in renegotiating. So a lot of them go into those extension periods. But basically what that means is that the reason I point that out is that the managed Medicaid plans are very well aware of what's coming down the pipeline. They want to make sure that they understand if there's a gene therapy, if there's a high-cost drug, if there's a drug like that's applicable to a large patient population and may have an expensive price tag. They want to understand how their insurance model of revenue and expenses is going to be hit. So they're always doing that, and they're really trying to predict what's going to happen and when. And they're very active on the state's radar screen as far as lobbyists trying to, in some instances, lobby for a carve-out of a certain expensive drug and say, hey, take this out of managed care and this belongs in fee-for-service. There's a lot of effort to do things like that, but we're seeing less of it go through because the states are really trying to enforce the concept of managed care where, yes, even if there's a high-cost drug, you're still responsible for that. And you know, there's a chance you may not even have a patient. It's that rare of a disease. But in my experience in industry and in consulting and over the last 20 years or so, it appears that managed Medicaid is really one of the strictest controlling markets. And that's because they have a fixed revenue stream coming in, and the only way for them to figure out or influence their ROI or net income is by trying to restrict treatment if it's not necessary. So the argument is this drug or is this treatment medically necessary or not? And that becomes a source of friction between drug manufacturers and managed Medicaid plans, and that's one of the areas that we focus on to try to figure out, you know, what makes sense, and are we missing something in the messaging, or are people who are not medically appropriate for this drug trying to get the drug? So it also leads to newly launched drugs being some of the last to be covered by managed Medicaid plans, meaning that out of the commercial Med D, ACA, fee-for-service, managed Medicaid is typically the last market segment to cover a new drug. So everybody wants to utilize generics and maximize the generic utilization rate, but we want to make sure that's done responsibly and not to the detriment of patient outcomes in managed Medicaid. The good thing is that if on the medical side, the medical benefit drugs are typically covered either to guidelines or not really even managed restrictively by the managed Medicaid plans. So that's something favorable as far as coverage access. When I mentioned that managed Medicaid plans are similar to commercial plans, and that's because they're on a WAC pricing basis. The only difference is that their plans are really made up of Medicaid patients. And the second big difference is that you're paying a federal Medicaid rebate on that utilization. Okay, but again, just remember that when you pay that federal rebate on managed Medicaid utilization goes to the state and not the plan. Plans are aware of that, and they know that you're already paying a steep Medicaid rebate, and they're used to getting smaller rebates than their other market segments just because of that. And you need to be aware of that and make sure your financial folks in-house are aware of that too. This leads to that dynamic where the price of drugs is heavily factored or heavily weighted when determining coverage criteria for newly launched drugs or adjusting coverage criteria for existing drugs. Again, they're going to try to force the use of a preferred drug, a formulary drug, or a generic drug, and potentially walk through several step edits before getting a brand drug. If, however, there is a medical necessity and the provider is able to walk through and document the medical necessity or the trial and failure of the preferred drugs, then it could be easier for that patient to get approval for those drugs. So I mentioned that there are 260 plans across the U.S. today, and it's really important to look at them and organize, target, prioritize so that you can really hit this market efficiently and effectively. And we do this by, one, keeping tight enrollment numbers and monitoring these, the lives that are managed by these plans, and consolidating them into what we call the national plans that play in more than one state under the same umbrella, and independent regional plans. And we organize them by lives, and it's really important to do that unless there's a certain geographic distribution of the disease state that your drug is in. Because again, you're going to be working the most efficiently by hitting the lives where they are in those plans. So by organizing them this way, you have 20 or so top managed Medicaid plans that you really should be proactive with. And we can arbitrarily include more plans or fewer plans depending on the level of account management that you have. We can also support your account management team to add more accounts to be proactive with. But it's important also to cover the PBMs that these plans roll up to, because this is, again, more like the commercial market. And just about every one of the top plans rolls up to a commercial PBM. This is a cut without looking at a particular drug class. Okay, so what we do at Artea is work with the rest of the group, and we identify the drug, the class, who's managing that as far as statewide PDLs, any carve-outs, and then we create this customized list based on actual control of the managed Medicaid plans for your drug or your therapeutic area. And that list will change based on the states that manage or don't manage that class. So it's a critical thing for us to do, to identify, target, and prioritize the key managed Medicaid plans for your specific drug. Basically every drug manufacturer or every drug class is going to have a different cut at these accounts. Okay, the new drug coverage decision process takes a while. You know, we set the we set the bar by saying that we should not expect managed Medicaid to start covering a newly launched drug within 4 months. 4 to 6 months, most of the time you'll get coverage. There's going to be some laggards that are out there that take longer than 6 months. But a lot of things happen similar to the commercial world, similar to fee-for-service. This slide, again, depicts kind of what happens at the manufacturer level, working with the plans and the PBMs, and potentially doing some contracting or negotiating, and also the different players that influence the managed Medicaid plans in how they cover a new drug. Okay, and I'm going backwards now. All right, but basically, if we lumped together, you know, and created 3 buckets, this is what they'd look like. 4 to 5 months, you'd see United and Fidelis. These guys tend to act a little quicker than the rest of the group. And then you have several plans that are what we call standard at about 6 months, and also several plans in the delayed group, which are longer than 6 months. So it's important to set these expectations with the people internally, because fee-for-service and managed Medicaid operate on 2 completely different schedules. And sometimes internally, your executives look at Medicaid as just one bucket, one market segment. So it's really important for them to understand that this managed Medicaid segment is going to be the last group to add. Okay, keys to working with managed Medicaid plans. The key is, the biggest key is price. If there is something that differentiates your product from the standard of care, if it's a rare disease, unmet need, lower cost, or saves, you know, it has an economic model that keeps patients from having steep medical costs, that is something that's going to resonate with the managed Medicaid plans. Again, they're paying WAC price for the drugs, and their goal is going to be to avoid brand drugs wherever possible and use the generics or use the standard of care. But if there is a major differentiator, that is where they'll lean in and listen. Do your homework. Know how many, you know, based on the number of lives in the disease state, we can help you identify an estimate of how many patients, just based on statistics, would have this affliction per managed Medicaid plan. And that could be independent regional or at the umbrella national plan level. Because a lot of the payers in any market segment don't exactly know or don't do the translation into how many patients does this mean for me. And they also expect, you know, when they say, all right, so this will hit 1,000 of my patients, they also expect those 1,000 patients to come in day one and get the drug approved on the same date and have the budget impacted on that day in that month. And that's typically not how it works. It works over time. It ramps up. So you may have X number of patients in the first quarter. Give them a timeline of this year and next year by quarter, how many patients you would expect to have uptake on this particular drug. They're concerned about the budget impact, and you have to address that and alleviate those concerns. I talked about the timing dynamics. That's that, you know, talk about the number of patients and then talk about when those patients are going to come in. And it's okay to, you know, and this is all, you know, based on approval of your company, but I recommend actually taking whatever you can from your company that they're showing Wall Street as far as uptake and translating that to showing the timeline for this particular market segment, so that they can see that this isn't just something that you pulled out of the air. You're using it publicly, or you're using it to gauge for the financial markets too. These plans, most of them have multiple books of business, meaning Medicaid, Medicare, commercial, ACA, and you don't need a separate meeting to talk about the managed Medicaid book of business. Consolidate wherever you can. The payers and the PBMs alike will appreciate you doing that and saving them time and not asking for multiple meetings to go over the same thing. Typically, it's the same group of people who are going to make the coverage decision for the different books of business, even though they may have tweaks or maybe more restrictive in managed Medicaid than a commercial book of business. Okay, and the PBMs are very influential in the managed Medicaid market segment. So they should be treated as tier one, and the same thing goes for them. They have the multiple books of business too. Make one meeting with the big PBMs or in the medium-sized PBMs to cover all books of business that they cover for their client plans. And it's vital for you to get either a neutral or a positive recommendation for your drug from the PBMs. So you want to get as much information from the PBM as possible, as far as, and educate them as much as possible on how they can communicate the benefits of your drug to their client plans. And, oh, okay, and the last point is really to work with KOLs. You're always working with KOLs. The sales team is working with KOLs, but payers and PBMs listen to KOLs a lot more than they listen to an account manager. So if you can encourage the KOL to give feedback about what's appropriate and what's inappropriate coverage policy for your drugs directly to the plans, and tell them why this PA rejection is wrong or why this is medically necessary, that is going to go a lot further than you calling the plan. So engage your KOLs, teach them how to talk to the plans, and that investment will pay dividends for a long time. All right, and again, the last thing, go to Association of Health Plan conferences. A lot of states have these, and it's a way to interact directly with the plans outside of an individual meeting. I think that's it. All right, so we're going to take a quick break, 5 minutes, and we'll get going again. So we'll see you soon. Thanks.
up to now, sort of, kind of, maybe might apply now that we move into the Caribbean space. The real Caribbean, by the way. En otras palabras, el verdadero Caribe. And this is actually a little bit of a twist on events too. You still, okay. A little twist on events too, because I actually have a virtual speaker with me, and you see him right there up on the screen. He is the Puerto Rico Medicaid director. He actually runs what in Puerto Rico we call the Puerto Rico Health Insurance Administration, which is the public agency that is responsible for running the Medicaid, or most of the Medicaid program in Puerto Rico. What I'd like to do this afternoon is, because we sort of have that little change of gears, given that we're in the Caribbean, is go over some of the facts and figures that make us just slightly different, and also set the framework for those of us here with us this afternoon. You'll see that the first bullet I've got here is that our population is at around 3.2 million, according to the 2020 census data. The actual real number is 3.18 million as of, I guess, about a month or two ago. So we are seeing a little bit of negative decline in the population for all the factors that you can surmise. Another little tidbit of important information is the amount of our population that is over the age of 65, which is at 15%, so that the Gaussian curve is really skewed towards the right. And our median age is around 40, and the average age is getting close to 44 years of age, which supposes a number of demographic changes. The other little tidbit that's important from a Medicaid perspective is our workforce participation rate, which has been at around 40% for quite some time. So part of the differences that you see reflected in how the Medicaid program is managed are attributed to our formal versus informal workforce participation rates. Another little important piece of information is the size of the biopharmaceutical industry, which, as of last year, the total volume of sales is estimated at around $3.6 billion, which, if Puerto Rico were a state, would more or less be about 25, 26, 27, 28 in terms of the rank, so right in the middle in terms of a manufacturer product consumption. And our total healthcare spend in terms of the entire ecosystem is at around $15 billion. And that includes both premium dollars as well as the portion of services that is rendered by the government. Because in Puerto Rico, the government is a provider of healthcare as well as a payer of healthcare. This is the official census data number, the 3.285. That has gone down slightly, as we just commented. And then the Medicaid population is at around 1.236 million lives, or around 38%, more or less, give or take a little bit, of the total island population. Of that 1.2, I'd like to call out the fact that there's a number of public employees that are eligible to participate in the, I guess, expanded Medicaid program, and that figure is at around 113,000 lives. Interestingly enough, as we were covering relative to that 15% of the island that's over the age of 65, we have around 700,000 residents that are covered under Medicare. The important footnote to call out there is the amount of Medicare beneficiaries that are actually in a managed Medicare plan, and that is at around 583,000 lives. That makes the Puerto Rico's managed Medicare program the highest penetration rate program in any jurisdiction in the United States, and that is by a significant margin. Of those, about 283,000 are dual eligibles, and obviously that number gets adjusted up and down pretty much every 30 days. The other important item I'd like to call out, we've got the breakdown of the A and B lives, is that the Part B program in Puerto Rico is an opt-in program, not an opt-out program, like it is in most of the United States. So what does that mean? When a resident of Puerto Rico turns 65, that person has to affirmatively state that he or she wants to enroll in Part B of Medicare. You don't normally see that, and that has a number of socio-demographic factors as to why the legislation was drafted that way. So that is why, part of the reason why you find many people do not sign up for Part B, and that creates discrepancies, as we'll be chatting about in a little bit here. Our total uninsured, though, interestingly enough, is really not that high when you compare it to the rest of the population. You're pretty much looking about 8% of the population is completely uninsured. Our core issue is not uninsurance. Our core issue is underinsurance, because there are a number of plans, especially on the biopharmaceutical drug side, that do not cover a number of products or offer very little coverage, because most of the ACA provisions do not apply in Puerto Rico. What I'd like to do with this slide is drill down a little bit into what that $15 billion number is about. And what this slide depicts is how the premium dollars break out in Puerto Rico. And approximately about 12 billion of those 15 billion that I mentioned are premium dollar amounts. And here's where you see the green side of the pie is where the Medicare Advantage premium dollars are in comparison to the Medicaid program and private coverage programs. And there's where, although most of the population resides in Medicaid, what you'll see is that most of the premium dollars are not in Medicaid. Most of the premium dollars are with Medicare Advantage plans. So what tends to happen from a practical perspective in the market is that your Medicare Advantage plans become the equivalent of what commercial coverage would be in any of the states that you're looking at. So the behavior is different. And you'll see that on the second pie chart, where you see that most of the lives are in Medicaid, but not necessarily most of the premium dollars, where you compare, if you would, the blue and the green colors from one side to another. And the little table here at the bottom is interesting, because there's where you see how the actual membership versus the premium dollars are breaking out. And for purposes of our conversation here, when you see the Medicaid dollars, you've got 39% of the total lives, yet the funding is significantly lower. But then when you look at your Medicare Advantage group, the membership is lower, but look at that 55%. And what the footnote there is depicting is also important, because that's where the dual eligibles, most are residing in that 55%. Puerto Rico doesn't have the rest of the other special Medicare categories, the qualified low income and the QBs and the SlimBs and all that. What we pretty much just have are dual eligibles. So we tend to focus a lot on that number, because the majority of them have elected to enter into a Medicare Advantage plan, and there's where you see that significant shift in population and premium dollars. Notice
Elaine?
also the commercial premium dollars, which are 19%, yet the membership is 33%. So really, it's your Medicare Advantage plans are really behaving like commercial carriers in the market, and they've got a pretty high percentage of dual eligible. So that's why we take a closer look at it, because of the Medicaid component there.
Yes, Elaine? I'd like to chime in with some information that might
And
be
now what I
relevant.
would like to do is have our virtual speaker review a few of the slides that have specifically to do with matters relative to how the budget is breaking out in Puerto Rico. And we've had some significant changes from a downstream perspective as of last Friday. So we will cover those as well.
Sure. Thank you very much, Elaine. Can you hear me?
Jorge should come on now.
I should.
Okay, excellent. Except
All
we
right.
can't see you, but carry
Oh, you
on.
can't see me. All right. I'll just go ahead and carry on. And first of all, thank you very much for the invitation and for Artia giving the information that we're discussing this afternoon. First of all, I'd like to point out something that's very important in understanding the dynamics of the Medicaid program back on the island. We have suffered a swift decrease in the population of Puerto Rico, but that is not the only effect. It has only not decreased in the number of people on the island, but also we have suffered a swift process of adverse selection, meaning that the population leaving the island is typically younger than the one remaining on the island. On average, the group that has out-migrated is 11 years younger than the group remaining. So that means we have an older population, and typically it's a population that is sicker. The second thing I wanted to point out is that in describing the population insured by Medicaid, Helene mentioned the public employee group. This public employee group used to be what we call the pure Commonwealth group, but since the poverty level in Puerto Rico was raised to 85% of the federal poverty level, almost all that group was absorbed into the Medicaid program. So there's only maybe 20 to 25,000 people left in the pure Commonwealth group. Everybody else is insured under Medicaid at this point, meaning that the program nowadays has approximately 1.5 million people insured under its care. So I wanted to make this this update in terms of everybody understanding that the numbers that Helene showed you in terms of the dollars available and the population covered, well, yes, we do not have the majority of the dollars, but we do certainly have the largest plurality of the population insured. In terms of the budget allotments, Section 1108 of the Social Security Act caps the federal contribution to the Medicaid program at approximately $398 million. And this cap is pretty much reflective of the way it was put together back in the 1960s when Medicaid was extended to Puerto Rico. They did not extend the same type of coverage they have financially in the States and decided for a cap. That cap has been modified over the years, but typically it has not reflected the increase in the cost of managing the program. So one of the biggest problems we have, and that is illustrated in the bullets below the Section 1108 bullet, is that we have had to look for supplementary revenue to be able to fund the program over time. And you can see that in the period of 2018 to 2019, this was $366 million. From 2019 to 2021, it was $2,716 million, including $93 million in the CARES Act, the Coronavirus Response Act. And from 2020 to 2021, we had $2,883 million, including $107 million from the Families First Coronavirus Response Act. What are we looking at right now? Well, in terms of what was the projected forecast by the Oversight Board in Puerto Rico, which is the agency in charge of managing the bankruptcy of the Puerto Rican government, we were expecting numbers that reflected the fiscal cliff that was scheduled to start on October 1st of this year. Now, fortunately, last Friday, there was a bipartisan agreement entered by members of the Senate and also backed by members of the House, whereby Puerto Rico is going to basically receive the same amount of money that we received for the last fiscal year over a period of 5 years, starting in fiscal year 2022. In 2022, in addition, we're going to enjoy an FMAP of 83%, which will then be lowered for the next 4 years to 76% FMAP. So that is the situation right now. If that agreement holds, and we have every indication that because of its bipartisan nature, it will hold, this means that Puerto Rico will have averted the fiscal cliff. It will not be, however, in a position to provide the full complement of services mandated by Medicaid because of a shortfall of funds, but we won't be in the dire condition of having to disenroll hundreds of thousands of people because of the shortfall in money. And this is very good news for Puerto Rico indeed, and the Medicaid program is forecast to be able to continue covering this substantial amount of Puerto Rican population over the next 5 years.
Okay. I think then with that, do you want to enter into details of the next slide, or we just keep going?
Oh, the
think
first
we pretty
slide,
much covered
basically, the next slide, basically what does is a breakdown of the special allotments of money that have been provided to Puerto Rico since 2018. And it's reflective of the efforts Puerto Rico has been forced to make in order to acquire supplementary funds to run the program. Given the cap, which is very low in terms of the cost of the program, running the program, the Medicaid program in Puerto Rico, cost Puerto Rico $3.7 billion this past fiscal year. So that gives you a pretty good idea that a $400 million cap is totally insufficient to cover the needs of our medically indigent population. So as you go down the rows and columns on this slide, you will be able to see how Puerto Rico has benefited from allotments of money over time without achieving a permanent solution. The 5-year provision of money that was negotiated in Congress is not a permanent solution either, but it enjoys one very important aspect. It is much longer than the ones we have enjoyed since 2018, which gives Puerto Rico a platform for greater stability in the Medicaid operations, and also allows us to generate our game plan to achieve state-like parity over this period of 5 years, which is the stated goal of our governor, and has also been backed by President Biden and the Democratic leadership in Congress.
Then we'll get a little bit into the Medicaid program management.
Sure. Puerto Rico has had a head start on managed care for Medicaid over most of the states, if not all of the states. Back in 1993, as part of a comprehensive reform of our healthcare system, then Governor Rosselló decided to privatize most of our public hospitals. In doing so, he also launched a government-sponsored health insurance program to cover the medically indigent population of Puerto Rico. And it was developed around the concept of managed care, with your primary physician in the traditional position as a gatekeeper, based on capitation provided for the primary care physician groups, or IPAs, independent practice associations. And these IPAs would receive a per member per month amount of money that would provide them the funds to handle their populations over a period of time. At present, we have 4 private carriers in the program. The carriers are Blue Cross Blue Shield through their operating arm in Puerto Rico called Triple S. We have Triple M, which was recently acquired by Anthem. We have First Medical Healthcare, which is a local corporation, and Plan de Salud Menonita. The carriers pay for the cost of drugs as part of their PMPM, And through this process, the liability for biopharmaceutical products is retained by the participants in the program, by the MCOs, the managed care organizations. So they are at risk at diverse degrees for this kind of medication. And we have no fee-for-service Medicaid under the organization of our Medicaid program in the island. So this has been a full managed care since 1993, full capitation since 1993, with some of our specialists and hospitals receiving a fee-for-service, but that fee-for-service is based upon a segmentation of the PMPM, which provides the funding for the payment of the fee-for-service paid to these specialists and hospitals. The target MLR is 92%, which is probably the most stringent MLR percentage that has been provided in any Medicaid program under the United States flag. The payment methodology is based on rate cells, 37, population tiers, and uniform provider payments. And finally, the medical loss ratio is calculated using federal rules. This administrative expense is $8, so 8 cents on the dollar. Of course, there is a number of arrangements between the provider networks and the MCOs, which makes the actual MLR vary in its amount. And that is one of the challenges that we have as the administrator of the Medicare managed care portion of the program, is to make sure that we understand how the dollar moves through the system, and how is it that this 8% administrative expense is actually reached, even though the MLR can be diced and sliced in diverse ways as the provider networks contract with the MCOs. Finally, MMIS is being established in phases. The MMIS is a Medicare Management Information System. We are actually undergoing the third phase of implementation on the island. And this means that we are integrating the systems at both the Medicaid office level and the Puerto Rico Health Insurance Administration level. We are providing for a sole source of truth, which means we would have not only the enrollment data for the providers, but also the financial data for the creation of payment for the MCOs, and also share all the files and information regarding the beneficiaries of the program, meaning that when we have full integration with MMIS, we will have a granularity of information at our disposal, but also we would have integrated both the Medicaid office and NSS into a seamless operation, achieving substantial savings because of economies of scale, and also increasing the efficiency of our operation throughout the island.
Excellent. Now let's talk a little bit about the actual drug spend in Puerto Rico. Our total gross outpatient drug spend for the fiscal year just closed a couple of weeks ago was around $799 million. Of that, the government collected about $307 million in rebates, or more or less around 38% of that gross spend amount of close to $800 million. And then from there, the average rebate for those products that are contracted on the Puerto Rico PDL is around 35 to 40% off of WAC, is more or less the average rate. Now that's important because Puerto Rico, as you will see, is the way the PDL works in Puerto Rico is not exactly the same way as the PDL works in the rest of the United States. Our net outpatient spend is more or less around $492 million when you net out the rebates, and of special call out is the amount of money that is spent on specialty drug products, which has risen substantially over the last few years and is now up to over half of the gross drug spend in Puerto Rico is going towards specialty drugs, under the same definition that we're all used to in specialty.
Elaine, if I could chime in here, because
that growth has been, I believe, over $100 million over the last 4 or 5 years per year. So it's been significant increase for a number of different factors, because of a number of different factors. I'd like to call out some of the differences between how the Medicaid drug program is actually operationalized in Puerto Rico versus what we're used to seeing in the rest of the United States. The first thing is best price does not apply in Puerto Rico as of right now. There is regulation that has been pending for a number of years and has gotten postponed as to whether or not MDRP would apply in Puerto Rico. This has been going on more or less for about a decade. As of right now, it appears that MDRP won't be applicable until at least January 1st of 2023, or probably more likely somewhere between that date and April 1st, 2024. The last regulation that you may or may not be familiar with had MDRP kicking in April 1st of next year. Important differences also to call out. There's no rebate clawback in Puerto Rico, so the negotiation is directly with the Puerto Rico Medicaid. Therefore, Puerto Rico does not report prices paid in Puerto Rico to CMS because there's no clawback. And the reason for that is because Puerto Rico is not part of the existing CMS rebate agreement. If you look at the definition of the term state in the original MDRP regulation, it does not include the territories. Therefore, as a manufacturer, if you choose to approach Puerto Rico Medicaid about achieving access for one of your products on the PDL, and by the way, the PDLs are all available online, probably the best framework to use to analyze it is this is a voluntary or a supplemental rebate, because you're not reporting that rebate to CMS. And just as a footnote, LIS does not apply in Puerto Rico. We have a different arrangement. It's an arrangement where those Medicare Advantage plans that I was alluding to that have the population of dual eligibles get paid $10 PMPM as a more or less surrogate to LIS. Also, as a footnote, the copays that are paid under Puerto Rico Medicaid are very minimal, and a number of products do not even have a copay. Part of and what will become important as we move on is as MDRP does get implemented in Puerto Rico, that goes hand in hand with what Jorge was just mentioning relative to the implementation of MMIS. The importance, part of the reason for needing the MMIS is then to be able to report all the rebates and clawbacks. And now we will flip back to Jorge so he can walk us a little bit through how the actual drug program is managed.
Thank you, Helene. We have two contractors who take care of our drug management program. One of our contractors, MCRX, which was formerly Procare RX, contracted in 2001. Basically, they take care of the whole network management and contracting, defining reimbursement, branded reimbursement at AWP minus a determined percentage. And it contracts with approximately 300 pharmacies, Walgreens and CVS retail, and out-of-network providers. Processes claims, and of course runs the P&T and pharmacy benefits financial committees and provides administrative support to that. Abarca Health, contracted since 2005, runs the PPA program, the rebate contracting and invoicing, and updates all the drug formularies, and of course presents financial analysis to the finance committee, and also provides advice to assess in terms of the best practices in order to maximize our rebate advantages when negotiating any of our drug contracts with the pharmaceutical companies that are our business partners. At this point, Assess, because of its commitments to the federal government, is undergoing a process of reforming its contracting processes. And one of these commitments involves making the contracting processes more competitive. That means that we have let out an RFP for the continued contracting of both our PBM and PPA. So, matter of fact, today, June 12th, we received the proposals of the competing companies that have indicated their interest in providing PBM and PPA services for Puerto Rico. We have already constituted technical committees to review those proposals, and it is our intention to have the whole process of reviewing the proposals and adjudicating the favored proposal around August or September of this year, if everything runs according to our calendar.
What I did was I fast forwarded to the slide where we were going to cover the RFP process, just so everybody could see. But it's pretty much what Jorge just summarized for us. And coincidentally, today is the day that those proposals are due. And actually, since in Puerto Rico we're an hour ahead, so those proposals already have to be turned in. If not, they
That's
are
correct.
technically late. So, and that was not planned, by the way. But, and this is important because as you just saw from the prior slide, we haven't had a competitive RFP process in quite some time. So since we covered that slide, I'm going to go back now to where we were to the prior slide. Okay. And then now, let's cover how would we go about adding a new product. Hey, Jorge, you'd like to cover this?
Oh, sure. It's a process whereby we utilize the advice and expertise of MC21 for a clinical presentation, and we contact Abarca Health so we can see the term sheet proposal. MC21 drafts a clinical summary and presents the product to PNT, which evaluates and presents recommendations, and Abarca also evaluates the rebate proposal and negotiates the rebate contract. I want to point out that since several months ago, we organized alongside the PNT, which looked more at the clinical and pharmaceutical evaluation side, the clinical effectiveness of the proposed medications and drugs. We put together a finance committee, which is very important because the financial impacts that we're having, especially from the new drugs coming online, and basically on the biologicals, they represent a huge challenge for the program. So having a clear understanding of the financial impact and aspects of the new drugs coming online is very important. And this financial committee is an adjunct to the PNT to make sure we get a rounded picture of the drugs that are coming online and how is it we can best face the challenge that the high prices of some of these drugs supposes for the program can be managed.
I think that'll be a continuing challenge as new biologics are developed. I'd like to call out a few differences that we have in terms of how the PNT is managed in Puerto Rico and how the actual process goes, because it's a little bit different from what you may be used to in other jurisdictions. The first thing you'll notice in Puerto Rico is manufacturers are not allowed to attend or present before either one of these two committees, the financial committee that Jorge alluded to, as well as the regular PNT. The committees used to meet on a more regular basis. They met 8 or 10 times a year. That's kind of tapering down a bit, and they're meeting every 2 or 3 months. The agenda and the composition is also confidential. As we move to MDRP, some of these operational matters may have to be, if you would, changed in order to align with some of the regulatory requirements that will come under MDRP. But I get asked these questions quite a bit So I think it's important to call out that we have those differences. So we work with matters a little bit differently. We just covered the RFP process. Jorge's summary there was excellent. So where are we? So where are we today? And what are the, if you would, the positives and the negatives, and the challenges that we see in Puerto Rico? We've had a population decline, like we alluded to. That population decline has also affected the Medicaid program, so that has a number of budgetary as well as operational implications. We also have some challenges with physicians and other healthcare providers, but specifically physicians in terms of the number of providers that are choosing to leave Puerto Rico. The last statistic that we've been able to validate on those lines puts the figure at around 500 physicians that are leaving Puerto Rico on an annual basis. Keep in mind that pretty much the physician can move without much trouble because most, if not all of them, take the USMLE. Therefore, they are pretty much certified to practice in any jurisdiction in the United States. That also presupposes shortages in terms of some specialties, and some are pretty crucial, like neurosurgery. Even pediatrics are also on shortages, as well as ophthalmology and dermatology. There are a number of medically underserved areas as well in Puerto Rico. So we do have challenges along those lines, but those are matters that are, if you would, top of radar from a public perspective, and clearly a lot of eyes on this. The budget that Jorge reviewed for us at least gives us some comfort zone for the next 5 or so years relative to addressing the funding cliff issue, which is really the #1 issue that Medicaid has in Puerto Rico. It's an insufficiency of funds, and it's been an insufficiency of funds for a number of years. That right there poses another challenge in terms of financing for high-cost drugs. Where are we going to pay for all of this as we move forward? That lack and those funding challenges also, you will notice that a number of the mandated benefits don't necessarily import to Puerto Rico, and those are one of the issues that we'd like to address on a moving forward basis. For example, nursing home care and non-emergency medical transportation are 2 benefits that are not covered, yet Puerto Rico has always covered prescription drugs as part of its SPAs. So there's been a balance there. There's been choices to make depending on, frankly, population necessities. With some of the extra dollars that have been coming in because of the CARES Act funding and what have you, the agency at least has been able to add some additional benefits that were not available before, like, for example, a Hep C program, which for many years Puerto Rico was not able to cover Hep C. We are now covering Hep C under a specific pilot program. From a bigger picture perspective, like Jorge alluded to, we do have a control board that is in charge of managing the bankruptcy process that the Puerto Rico government is undergoing right now. And naturally, one of the top items is Medicaid, because Medicaid represents over 20% of the Commonwealth's budget. When you look at that population, that 3.2 versus 1.2 to 1.5 in Medicaid, it's a significant percentage of the population that is covered by Medicaid. We also have a challenge with HIE, although we are finally starting to be able to load providers up on HIE, and I think it'll be definitely not only an enhancement from a budget management operational perspective, but I think also from a programmatic perspective, being able to eventually migrate to electronic medical records and much more interoperability between providers, and frankly, get rid of a lot of the paper that is currently used, I think will benefit all of us on a moving forward basis. And finally, and this is really more my personal opinion and personal challenge as to what we have right now can only be improved. I'd like to see always the glass always half full, not half empty. And the current system that we use to deliver health care is really not robust enough to support, our growth. So in that sense, I think it's a wonderful and fantastic opportunity for many stakeholders to work together and craft positive solutions. And with leaders like Jorge here with us this afternoon, I think we have a wonderful opportunity to really, like I said, look up, not look down. And with that, I hope I have covered or at least highlighted some of the differences between what we normally see on a day-to-day basis. The other two slides that you have in the book, one is just giving you details as to how the population breaks out in terms of coverage by different regions in the island, and also the population that is with Medicaid versus a population that has chosen to enter into a Medicare Advantage plan. And this last slide gives you a direct web citation into real-time enrollment statistics, and those are updated pretty much every 30 days. And with that, unless we have any questions you would like me to address now, then we will move on with Ms. Kinsey. Okay, we haven't any questions? All right, fantastic. Then I guess we just, do we have a break? We have a break now. We have a little break now. How many minutes? 5-minute sharp break, because now the operative word is sharp.
Been paying every day.
Oh, I used to love to make you cry. It made me feel like a man inside. If I had been a man in reality, you would be here, baby, loving me. Now my nights are long and lonely, and I ain't too proud, babe, I just miss you so. Girl, but you're too proud and September and I really should be back at school. I know I keep you amused, but I feel I'm being used. Oh, Maggie, I couldn't have tried anymore. You led me away from home just to save you from being alone. You stole my heart, and that's what really hurts. The morning sun, when it's in your face, really shows your age. But that don't worry me none. In my eyes, you're everything. I laughed at all of your jokes. My love, you didn't need to coax. Oh, Maggie, I couldn't have tried anymore. You led me away from home, 'cause you didn't want to be alone. You stole my heart, I couldn't leave you if I tried. I suppose I could collect my books and get on back to school, or steal my daddy's cue and make a living.
Test, test. All right, guys, we have made it to Medicaid reimbursement and rebates. And just for time purposes today, we are going to start on page 38 of your booklet, if you have that printed in front of you. Matt is going to come back and hit drug reimbursement, these couple of slides that we have, as well as the VBAs at the very end. So, all right, so we will start with Medicaid rebates. In Medicaid, it's important for account managers to know that there's two sorts of rebates. We've got the Medicaid statutory rebate that is required. We also have optional supplemental rebates that manufacturers may choose to provide to the states for coverage of their drugs. So we're going to go into the nitty-gritty details of both of these. And so we'll start with the Medicaid statutory rebate. So in Medicaid, for a manufacturer to participate and have your drug covered under any and all of the Medicaid programs, you have to sign what they call the CMS National Drug Rebate Agreement. What this rebate agreement does is it does two things. One, it ensures that the states are going to receive federal match for your prescription drug. And two, it also creates this Medicaid federal rebate or statutory rebate. You might have heard of this as the 23.1%. If there is no Medicaid rebate agreement signed, there is no Medicaid coverage. Now, states may opt to choose to cover a non-CMS rebatable drug. However, that is few and far between because, like I mentioned, that agreement ensures that the state's going to receive federal matching funds for those prescription claims. With the federal rebate, also known as the URA, or again statutory, this rebate amount is applied to any and all of your Medicaid utilization. That's going to be your fee-for-service utilization, as well as any claims that are going through any managed Medicaid plans within these states. This federal rebate is calculated on a quarterly basis, and that calculation is defined in Section 1927 of the Social Security Act. So like Matt said, we're going to go into the nitty-gritty detail and read line by line of that Social Security Act. I'm kidding. So with this, for the Medicaid calculation for the federal rebate, this URA calculation is really made up of two components. It's made up of the basic rebate plus an additional rebate. And for brands, the majority of account managers are representing innovator drugs. And for innovator brand drugs, that basic rebate portion is going to be the greater of the product's AMP, or average manufacturer price, times 23.1%, or AMP minus best price. Again, that's going to be the greater of. For generics, this basic rebate is a little bit different. That's only going to be 13% of that product's AMP. However, both brands and generics also have the second component of the URA, and that is the CPI penalty, or the additional rebate. Essentially, what the CPI penalty is a penalty in a form of a rebate that manufacturers must owe on all Medicaid utilization, and you receive a CPI penalty for raising the drug's price above and beyond the rate of inflation. So when we talk about the URA, of course, best price is always a concern. We want to make sure that we understand the implications of best price and what that holds on your Medicaid rebate liability. So like I mentioned, that first portion, that basic rebate portion of the URA, is the greater of 23.1%, or AMP minus best price. So therefore, if a manufacturer goes out to a commercial plan and provides a discount greater than 23.1%, your base rebate in Medicaid is automatically set at that 23.1%. Now, we have a snippet of the definition for you of best price, but that is also defined in Section 1927 of the Social Security Act. And essentially, this is the lowest price available from the manufacturer to any wholesaler, retailer, provider, HMO, nonprofit entity. There are exceptions to this, including supplemental rebates that are provided directly to state Medicaid fee-for-service programs. So why is best price such a concern? Well, from the calculation that we just looked at, best price can negatively impact the amount of your federal rebate, i.e. increase that rebate liability that a manufacturer owes on their utilization. So if you're not discounting above and beyond that 23.1%, there's no worries. You don't have that best price implication of your Medicaid federal rebate. However, if you are discounting above and beyond that 23.1%, this includes commercial markets. It also includes discounts to manage Medicaid plans. So I know that was a question that came in through Slido earlier. Those managed Medicaid discounts do impact best price. So it's important that account managers understand this implication and how it relates to the Medicaid federal rebate when you're out there dealing with those commercial accounts. Again, just as a reminder, that rebate is owed on all of your utilization, fee-for-service, and managed care. All right, so the next set of rebates is supplemental rebates. These rebates here are optional in fee-for-service. And as Matt had went through, there are a number of states, the majority of states, who are operating preferred drug lists. These preferred drug lists are utilization management techniques that are really used to control the costs of these drugs and ensure that these patients are receiving access to clinically appropriate and effective drugs, again, while still controlling those costs. So the states use these PDLs to help leverage supplemental rebates that they receive from manufacturers. They promote competition by placing manufacturers' drugs in the same therapeutic class, and they look at these and compare both the clinical effectiveness as well as the cost. And so for a manufacturer perspective, manufacturers are able to pay supplemental rebates for preferential positioning on the PDLs, or preferred status. Typically, when your drug is preferred, you're sitting in an unrestricted position. Prescribers can freely prescribe your drug. There's no kind of barriers or obstacles in place. Whereas a non-preferred drug requires a doctor or provider prior authorization, and usually that prior authorization requirement also includes a trial and failure of maybe one or two or multiple of these preferred agents. So it really does pay to be on the preferred side of that preferred drug list. And like I mentioned again, supplemental rebates between the manufacturer and the state are fully exempt from your best price. So we don't have to worry about that best price implication for any discounts that we decide to provide to these fee-for-service programs. And so for all of the states, they all have a process in place to solicit for rebates, to analyze these rebates, as well as execute these supplemental rebates that they decide to accept. What we have here on this table is a view of the 3 purchasing pools, as well as a look at the independent states and their various process when they look at PDLs and they review these therapeutic classes, as well as supplemental rebates. So we'll go through here. We'll start with NMPI. So NMPI reviews their therapeutic classes. All NMPI states review their therapeutic classes on an annual basis. The thing about NMPI states is sometimes those reviews are pretty random. They're not very consistent year to year. We also have pretty short notices on those P&T notifications. With the bid timing for NMPI, we typically receive that solicitation from the purchasing pool in the fall, around October, November timeframe, and that contract is then effective the following April. The contract will actually be executed prior to April. You'll receive that contract from Magellan prior to that April 1 effective date. That ensures if the state accepts your supplemental rebate offer as of 4/1/21, that contract is in place and eligible to collect those rebates. The next purchasing pool we have is TOPS, or the Optimal PDL Solution. Again, similar to NMPI, the top states review all of their P&T classes on an annual basis. The good thing about TOPS is that these are always consistent year to year, so we know what cycle our drug is going to come up for review. With that, TOPS has 2 P&T cycles, one in the spring, one in the winter, one in the summer. And for that, we also receive the bid timing twice a year as well. Contract execution, similar to NMPI, is prior to all of those P&T meetings, and the manufacturer is also actually going to receive 1 supplemental rebate agreement that will stand for all of the top states. Now, like Matt had mentioned earlier in his presentation, those states do have the autonomy to accept the offer or reject the offer, but your rebate does go out into the entire purchasing pool. The third pool here is SSDC. SSDC reviews their products on an annual basis. Typically, all of those categories on the PDL are reviewed at 1 meeting per state, and that happens in the fall and the winter time. The bid timing for SSDC is a little different than what we see for the various other pools and the independent states. We receive the bid for SSDC in the April timeframe or the spring, and the bids are actually effective that following January for the next calendar year. That contract execution, again, will be prior to those P&T meetings that are held in the fall and winter. And unlike NMPI and TOPS, a manufacturer is actually going to receive a direct contract between the state and the manufacturer for each of those SSDC states. You will not receive one umbrella contract like the NMPI and TOPS purchasing pools. We also have a handful of independent states, and for these, typically, these states are all reviewing their therapeutic classes on the PDL on an annual basis. Usually this happens on a quarterly basis, so we typically see about 2 to 4 P&Ts held a year for these independent states. And for the bid timing, typically we receive those solicitations about 12 weeks in advance of those P&T meetings. Contract execution is very similar. That's going to happen prior to those P&T meetings because, again, as soon as the state reviews, they decide that they'd like to accept your supplemental rebate offer, they have that contract in hand and it can be executed timely. So with all things Medicaid come acronyms, and supplemental rebates are no different. So we have a few terms here that's important for account managers to be aware of when you're discussing supplemental rebates with Medicaid. The first of which is a GNUP, or a guaranteed net unit price. This is essentially a supplemental rebate formula that the majority of the states use that provides a net price per unit that a manufacturer agrees to for the term of that contract. The purpose of the GNUP, and we'll get into that formula in just a moment, is to calculate the amount of supplemental rebate that the state is going to invoice the manufacturer for each quarter of that contract term. The next terminology is percent of WAC. Essentially, this is a supplemental rebate formula where a manufacturer agrees to pay a certain percentage of supplemental rebate above and beyond that statutory rebate for every unit of the drug. The next acronym is SRA, or Supplemental Rebate Per Unit. Again, this is that additional rebate that a manufacturer agrees to pay in addition to that federal URA. And the last is URA, and we've already reviewed that. That is your unit rebate amount, also your federal or your required statutory rebate. So we'll go into the details of the GNUP calculation here. And what's important to note is that the majority of the states do use a WAC-based GNUP. This formula here you can find on the screen is essentially WAC minus the federal rebate minus the supplemental rebate equals your GNUP, or your guaranteed net unit price. And we'll get into the algebra here in just a couple minutes. But a couple of other states that we wanted to make sure we called out, these states do use a variation of the GNUP formula. Texas uses an AMP-based GNUP, so instead of starting with the product's WAC price to calculate the supplemental rebate, Texas is using the product's AMP, or average manufacturer price. Kansas uses a fixed net cost formula. They use WAC plus 4.6% as their starting point for that GNUP calculation, which is Kansas's old pharmacy reimbursement. However, they have not updated their supplemental rebate contracting formula to reflect this. Medi-Cal is unique, as always, and Medi-Cal actually allows manufacturers to provide supplemental rebates as a percentage of your AMP. And so again, that GNUP is a dollar value that is going to be placed into the contract for the entire term. So we have an example for you here. So let's say we've got drug A. It has a WAC price of $1.05. Its current federal rebate is sitting at about 45% of that WAC, or about 47 cents and some change. This manufacturer is okay, and they would like to provide the supplemental rebate of 10% to the state. So that supplemental rebate amount you'll see is 10.5 cents, or 10% of the WAC, and that leaves us with the GNUP. So again, we start with the WAC, and then we subtract out those rebates to leave us with the guaranteed net unit price that the state will pay no more for the product through the term of the contract. So what the state does with this GNUP formula, like I mentioned, is that they use this to calculate the actual supplemental rebate that the state is going to invoice the manufacturer for the term of that contract. So this is calculated each quarter. First, we're going to start with that GNUP formula we just reviewed, WAC minus the URA minus the SRA equals our GNUP. For every quarter of that contract term, we have 3 static references here that we will always have. We'll always have our reported WAC, you will always have your quarterly URA calculation, and you have your GNUP, again, that's listed in the term of that contract. So what the state does is they use simple algebra, and they're going to solve for that supplemental rebate amount each quarter. They're going to plug in the product's WAC price for that quarter, that product's quarterly URA. They're going to subtract out that GNUP, and that ends up with your supplemental rebate amount per unit that the state's going to invoice you for that quarter of the contract. All right, so along with the various utilization management techniques, such as statewide PDLs and carve-outs, also has an implication on the rebate flows for manufacturers and how they receive invoices from the states. So we're going to walk through these various rebate flows and how those statewide PDLs and carve-outs impact these rebate management. So in a traditional drug management sense, we're talking about a state, for example, the state of Georgia Medicaid, who has a fee-for-service program who manages the coverage on their own PDL, whereas they also have managed Medicaid plans who are able to control their own formulary decisions within the state. So in our standard traditional drug management concept here, for a fee-for-service patient and the invoices that are received for fee-for-service lives, we're going to start at the bottom of this chart here. So we start with the recipient, and they go and they pick up their prescription from the pharmacy. At that point in time, the state then reimburses the pharmacy for that prescription drug claim. The state is collecting all of this utilization information to then invoice the manufacturer. So the state will then send the invoice to the manufacturer for that federal rebate, as well as any supplemental rebates the state might have been contracted with. At that point in time, the manufacturer then sends that rebate invoice back to the state, and that is where the payment lies. In managed Medicaid, in the same traditional drug management flow, start with the recipient, they go and pick up that same prescription from the pharmacy. However, now this recipient is a managed Medicaid recipient. So instead of the state being responsible for the payment to the pharmacy, the managed Medicaid plan now has to reimburse the pharmacy. So at that point in time, the managed Medicaid plan is collecting all of that utilization information, and they're reporting that to the state. In the meantime, in a traditional drug management flow, manufacturers may directly contract with a managed Medicaid plan. And so if a manufacturer has a contract in place with that plan, the manufacturer will receive an invoice directly from that plan for the managed Medicaid discount that they are contracted with. They will also receive an invoice from the state, and that state is going to be for your federal rebate on all of that utilization, including managed Medicaid. Again, the manufacturer then owes that statutory rebate invoice back to the state. So the next rebate flow we're going to look at is a state with a statewide PDL, or a single PDL. This is like a state like Florida or Texas, where the state is controlling the PDL, and all of the managed Medicaid plans are required to abide by that fee-for-service preferred drug list. And so in this case, you'll see there's no difference in the fee-for-service lives here. The recipient picks up their prescription, the state is responsible for reimbursing the pharmacy, and the manufacturer will then receive that rebate invoice from the state for any federal and supplemental rebates. On the managed Medicaid side of things, for a statewide PDL, this is similar as well. However, with this, manufacturers are not able to directly discount with managed Medicaid plans. And so in a statewide PDL environment, the managed Medicaid plan is going to report all of that utilization for their plan to the state, and then the state is then responsible for collecting any and all rebates for that utilization within their state, both fee-for-service and managed Medicaid. So the manufacturer then owes the state that supplemental rebate as well as any federal rebates. The last rebate flow we're going to look at is for a pharmacy benefit carve-out. Very similar to what we just looked at on the fee-for-service side. As a reminder, for a carve-out state, this is where the entire pharmacy benefit is being administered under fee-for-service. So the managed Medicaid plans are not administering or managing that pharmacy benefit at all. And because of that, you will only receive invoices from fee-for-service in a carve-out state, again, as the managed Medicaid plans are not responsible for that pharmacy benefit. So the manufacturer is going to receive a rebate invoice for that federal rebate, as well as any supplementals from the state for all of that utilization within the state. All right, so we're going to move into net cost and try to pull all of this rebate information together for you to show you exactly how the states are analyzing drugs on a cost and financial basis. And so when we look at Medicaid utilization and we look at drug costs, we use what they call a net cost formula. And this is how the states are evaluating the cost of medications, and they're comparing those to like medications. And so what the state does is they start out with their pharmacy reimbursement, or what they pay out to the pharmacies. They're subtracting out your federal rebate liability. They're subtracting out any supplemental rebate that the manufacturer might have offered to the state. they are then adding back in this lesser known portion called the unit rebate offset amount, or UROA. We'll get into the specifics of that momentarily. And that ends up with the state's net cost. So what's important from a manufacturer's perspective is when we look at this net cost formula that the states are using to evaluate their drug costs, from a manufacturer's perspective, your total rebate liability is made up of two of these components. It's made up of your federal rebate as well as your supplemental rebate, and that makes up your total rebate liability for that state and for your drug. So on the flip side of things, when manufacturers are evaluating your net revenue, or what you're going to be making from this deal, manufacturers evaluate this with a little different formula than the states are using to evaluate their net costs. So the manufacturer starts out with the WAC price. They then subtract out that URA. They take into consideration any supplemental rebates. They're also subtracting out any discounts to wholesalers or other fees that might be out there that are associated with the drug, and that ends up with the manufacturer's net revenue at the end of the day. So we're going to go into the components of each of these net cost references, and so first of all is the pharmacy reimbursement. So all states have their pharmacy reimbursement outlined in a state plan amendment, and typically this pharmacy reimbursement consists of a lower of methodology that you see on the screen here. Essentially, the state's going to look at various pricing references. Maybe the product's WAC. Maybe the product has a NADAC, or National Average Drug Acquisition Cost. If the state has a SMAC, or a State Maximum Allowable Cost, they'll also look at that, as well as the usual and customary charge. So they'll take a look at all of these various pricing references for a drug, and they're going to reimburse their pharmacies for any prescription claims at the lower of these pricing references. On top of that ingredient cost, pharmacies will also receive a dispensing fee. Typically, that dispensing fee is about $10 to $12 per prescription, and that does range by state. So the next component is the federal rebate. We already mentioned this, and we walked through the calculation of the URA. However, it's important to note here that not only is it important for a manufacturer to understand your federal rebate and how it relates to the drug's net cost, but it's also important to understand the competitor federal rebate, so we have a good understanding of what that landscape looks like for the financial environment we're walking into. And so what our TIA has expertise in is actually forecasting competitor URAs. So we take that calculation that's defined in the Social Security Act, and we actually use the CPI penalty portion to determine and estimate what is the current URA for our competitors. This plays a huge role into our predictive rebate model that we mentioned earlier today. And with this, it allows us to have a good understanding of where our competitors are at, so we have an idea of where we need to enter this market. The next piece of the net cost formula are the supplemental rebates. So again, I won't reiterate this as we've reviewed all of this information, but again, just to make sure you guys have an understanding that any supplemental rebates that are provided to the state between a manufacturer are exempt from best price implications. All right, so this last piece of the net cost formula is known as the unit rebate offset amount. Like I mentioned, this is a little lesser known portion of the net cost formula. However, with this, it's important to realize that sometimes your federal rebate does not go solely to the state. There is sometimes a portion of that federal rebate known as the unit rebate offset amount that actually goes directly to the feds, and the states do not get to realize this portion of your URA. Therefore, since they don't get to realize and take advantage of that portion, they're adding that back into their net cost. And so essentially what this UROA is from the Affordable Care Act, when the basic rebate portion was increased from 15.1% to 23.1%, The feds wanted to use this 8% increase to help fund portions of the Affordable Care Act. Well, at that point, as you can imagine, there was a number of products out there whose URAs were being determined by best price. So this would actually have been a cut to that state's revenue of the rebate dollars that they were already receiving from these manufacturers. And so the states and the feds came up with this 3-part test to identify if a unit rebate offset amount exists. And what this 3-part test does is it compares the difference between the product's AMP and best price to what used to be the basic rebate of 15.1% as well as the now rebate of 23.1%. So we'll take a look at this 3-part test here, and we'll walk through this. So if we look at part 1 here and we focus on drug A, the first part of this UROA test is if the difference between the product's AMP and best price is less than or equal to 15.1% of AMP, then the offset amount is going to be the full 8% of AMP. So if we look down at the table at drug A, we've got a product AMP at $1, a best price of 90 cents. And so our difference there, of course, is 10 cents or 10% of AMP. When we compare this to 15.1% or 23.1% of AMP, that is essentially lower than our 15.1%. So for drug A is going to meet part 1 of this 3-part test, and it will have a full rebate offset amount of the 8 cents. So we'll go to part 2. And with this, the part 2 shows if the difference between your AMP and best price is greater than 15.1%, but less than 23.1%, then the offset is going to be the difference between your 23.1% and your AMP minus best price. So if we take a look at drug B there, we've got the same AMP of $1. We now have a best price of 80 cents. So our difference is 20 cents or 20% of AMP. So this meets part 2 of that test where it's falling in between 15.1 and 23.1. So therefore, we're going to take the difference and we leave our drug B with an offset amount of about 3 cents. With part 3, we then look to see if the if the difference between the AMP and best price is greater than or equal to 23.1% of AMP, then the offset amount is going to be 0. So for drug C there, we have an AMP of $1, we've got a best price of 70 cents with a difference of 30 cents or 30% of AMP. 30% is greater than 23.1, and so therefore drug C does not have an offset and it meets part 3 of that 3-part test. So very similar to the URA that's calculated every quarter, the UROA is also calculated every quarter, and the states are utilizing this when they're looking at their drug costs. So to wrap this all up, what states are looking to do when they evaluate your drug costs in comparison to like competitors is they want to do this on an apples-to-apples basis. And typically what we find is that states are comparing competitive products on what we call a net cost per prescription. And what states will do is they will actually use their claims utilization, so actual data from their state and their patient population in their calculations to determine what is my average net cost per prescription for this drug and this therapeutic class. For products who have just entered into the market, or maybe the product has very little to no utilization in the state, what states will defer to until they receive actual claims utilization is looking at labeled dosing. So the state may pool clinical trial utilization, looking at averages of that patient population. They might look at maximum dosing comparisons to say, what is my worst case scenario on my budget for this drug? But at the end of the day, states are working towards a model that really allows them to compare these net costs on that apples to apples basis. Like I mentioned, that preferred model for evaluation is a net cost per prescription, but some therapeutic classes, some orphan high cost drugs do not fit into this category because of varying dosing regimens. So states may look at net costs a little different depending on the drug or depending on the state. We might look at that at a net cost per unit. Maybe that's a milligram or a milliliter level. A net cost per dose. Maybe we need to extrapolate that out on a net cost per day or month or year to make sure that we're looking at apples to apples across that whole therapeutic class. So in Medicaid, what's important really when we look at net cost, and this is very different than any other sector that we look at, is that because of the federal rebate calculations in Medicaid, legacy branded drugs can be up against high Medicaid federal rebates because of that CPI penalty portion of the URA. And so when we look at how brands compare to generics in Medicaid, some legacy brands, a lot of the time, are actually cost competitive to their generic counterpart. And so what we've got here for you is a real-life example of looking at drug A, a legacy branded product, compared to its counterpart, drug B, of its generic. You can see here as we work our way down this table, although the WAC per unit is significantly different, our brand coming in at $13 and some change, where the generic is coming in at $4 and some change. When we make our way down this table, that federal rebate is going to play a huge role into that net cost calculation. And so at the end of the day, when the states are taking consideration of these rebates that they're receiving, you can see in this comparison here that the legacy brand is actually significantly cheaper and a much better cost alternative than its generic counterpart. So we'll see that in Medicaid a lot, that the legacy brands actually might be preferred over their generics due to that net cost difference. All right, so that wraps up rebates. I'm going to turn it back over to Matt here to go walk us through value-based agreements as well as Medicaid reimbursement.
Thank you, Kinsey. So everyone knows that we actually give CE out for this course, but if you want your CE, you're going to have to pass a test for UROA. All right, I know we're probably all eager to get to the tin roof. I'm going to try to get you all out of here on time. And if we have time, maybe we can get Kinsey to go back over that UROA calculation one more time. Maybe we can get Jim Sharp over here to calculate it for us. All right? All right. Uh-oh, does that mean it's time to go? My clicker's not working. Here we go. All right, here we go. Okay, value-based agreements. I'm just going to spend a little bit of time on this. Basically, when it comes to value-based agreement, I know we got a segment on it as part of our material over the next couple of days, so I'm not going to go into it too terribly deep. Just know, again, they are out there. They are becoming more popular, but they have not taken off like one would have expected. States have the federal government set some guidelines with regards to these VBAs, and states have flexibility to administer their programs here. You're going to see typically two types. We talked a little bit about those today in a previous segment. We'll talk about them, I think, tomorrow or Wednesday. But about 9 states have federal authority right now to enter into either value or outcomes-based type contract arrangements. You can see those 9 states listed down there below. Then you have a couple of states that have entered into these population-based or cap financing models. Most of these have been centered around hepatitis C, where states have contracted directly with a manufacturer for a certain amount of funding with regards to that therapy, and that particular therapy can be distributed across the Medicaid population. When it comes to the VBAs, a lot of issues. One reason why they haven't taken off like one would think is centered around best price, that best price piece that Kinsey talked about as it relates to your federal rebate. There's a lot of issues out there with regards to VBA. So for example, if you're a pharmaceutical manufacturer, let's say you do a VBA with a commercial entity, and let's say maybe you're giving away the drug if the product doesn't meet the outcomes. A lot of these new orphan agents, some of these outcomes-based type arrangements require you to do that, or maybe it's a really high rebate associated with that. Maybe the population within that particular plan, there might only be 1 or 2 patients. So out of 2 patients, maybe you had one that didn't meet the outcome measure. Guess what you would have to do? You'd have to report that as a best price. If you had to refund all your money, your best price in Medicaid is now 0. It's been a very difficult situation to conquer when it comes to Medicaid, hence one of the reasons why VBAs hasn't really taken off. So what CMS tried to do is trying to help with that in establishing that rule. I'm not going to read the entire rule, but essentially what it does is it provides 2 regulatory pathways with regards to that best price. They have the allocation method, where if there is a failed outcome or there are multiple failed outcomes, they're going to proportionately spread that failed outcome over the best price that's reported. Again, trying to mitigate the potential there for your best price to basically be at 0 due to one of these outcome-based requirements. And at the same time, incentivize these pharmaceutical manufacturers to enter into these value-based requirements. Then they have a regulatory pathway number 2, where they're assigning maybe multiple best price to different outcomes. So manufacturers now have the ability underneath that final rule where they could, if a certain outcome in the VBA gets one certain type of best price versus another outcome. I'm not going to go into details, but that essentially is the gist of how it's managed. The goal, again, at the end of the day, is to manage your best price reporting to try to make it fair and equitable on both sides. When it comes to value-based agreements, basically today in the Medicaid program, there are 3 pathways. You have the list of states that currently have their state plan amendments that have been approved by the federal government. If you want to enter into one of these with one of these states, it generally takes you about 6 to 12 months to get that value-based agreement turned around, just depending on the state. But you can pretty much count on about 6 to 12-month time period. There are a lot of states that still don't have VBAs. If you're wanting to enter into a VBA with them, just be prepared. It's going to be a 12 to 18-month process, and it's going to may take even longer than that. Again, many of these states are in the middle of trying to draft their state plan amendments to get that federal authority, so it's going to take a while. Then you may want to try a value-based agreement directly with a managed Medicaid plan. Again, a state could decide to participate, but then you've got that CMS rule. You got to account for best price. So again, got to get the state's buy-in on that. You got to account for your best price as you're negotiating that value-based agreement with that managed care plan. And again, that could take upwards anywhere from 9 to 15 months. Your typical value-based agreement, when it comes to negotiating between you and a state, the typical term that we're seeing right now is about 1 year, and that's another issue. Stringing a value-based agreement out multiple years can be very cumbersome to a state just because of the budget cycles that they're on. They're on annual budget cycles, things like that. And then you have Medicaid member churn that can be problematic as well. So typical, what we're seeing right now is a term of 1 year that can be renewed for up to 5 years. Financial terms of the VBA can be through a GNUP, as Kinsey just mentioned earlier, or a percent or WAC. The clinical benchmarks associated with a value-based agreement are typically always negotiated between the manufacturer and the state. Can be tied to a PDL status. Negotiations and the agreement can also include impact on managed care. Portability has been a problem with the VBA agreements because if patient disenrolls in Medicaid, then the patient is typically not going to be eligible for that VBA anymore. Again, difficulty in tracking these patients. Member churn, things like that. So what's the art of the deal when it comes to VBA? If you're a manufacturer and you're trying to negotiate a value-based agreement, what's the give? You want to give a discount. You have to give something in form of a rebate. Again, if the clinical benchmark is not obtained, basically what we term it as put your money where your mouth is in terms of the clinical benefit of your product. So this can be in a form of a gene up or a discount off a whack. And then you're going to give measurement timing of when the benchmark should occur, and you're going to negotiate that with the state. What's the ask? What do you want in return? Well, it could be anything. Just about anything's on the table when it comes to a value-based agreement in that negotiation process. You could, if you have a new drug that's come on the market, one of the things you could ask in return is some expedited coverage determination associated with that particular drug. As I mentioned, in some of the new drugs that come on the market, sometimes it could take 6, 12 months. Some of these states have internal review processes. Some of them don't cover drugs right out of the gate. Or you could negotiate for prior authorization language, PDL status, and again, managed Medicaid compliance. So many things are on the table with value-based agreement. Now, I know I just flew right through that, but I wanted to make sure we get you out on time, and I wanted us to get an opportunity to go through a lot of the questions that we had that came in. So I wanted to tell you, all of you while you're here, what a privilege it's been to be able to provide this Medicaid 101. I know it's a lot of material. We try to pare it down to be associated with the pharmaceutical industry. Again, we could spend probably 2 days going over the Medicaid program if we really wanted to go through every single detail. So I know it's a lot of material. So right now what we'll do is we've got some questions. I know we've been logging. I've been taking a look at a few of them. And if we could post those up on the board. All right. Okay, so first question. This came in earlier today. Is there a difference between covered and non-covered versus preferred and non-preferred drugs? So definitely. Covered means whether or not a state is going to actually pay for your drug. So if your drug is covered, they will pay for it. If it's not covered, they're not going to pay for it. So basically, your product, again, not covered. If your drug is preferred, that means your drug is covered, but is being covered without any restrictions. There are no restrictions required. The doctor can freely prescribe your product. If your drug is non-preferred, your drug is covered by the Medicaid program, but there's probably restrictions associated with it, prior authorization, documentation of medical necessity. Next question.
I'll take this one, Matt.
Okay. Do you see any differences in the drug coverage state Medicaid, state managed and managed Medicaid preferred drug lists? Is one type broader in general? Is there a noticeable difference in utilization management?
Yeah, I'll say that in general, managed Medicaid is a little bit more strict, and you'll probably see more PA denials in managed Medicaid than fee-for-service. This kind of touches, though, on statewide PDLs, too. So if there is a statewide PDL and this drug is managed on that state's PDL, then the managed Medicaid has to abide by the state's coverage. That doesn't always happen. If you see an issue or if you get a report from the sales team that a drug is unreasonably being denied, and it's not adhering to the state's coverage policy, you need to raise that up to the plan, or we can help you do that and get the issue rectified.
Okay. Thank you, Eric. Next question is, are you seeing many states with mandatory white bagging policies for provider-administered drugs? That is, in my opinion, a very rare occurrence that we see. It happens, but we don't see a lot of those policies. But that's probably something that we would need to get our staff to look a little bit deeper in to provide a more comprehensive answer on that. Is the Drug Review Board for high-cost drugs independent from Medicaid? I don't know if Jackie, our legislative policy person, is still in here. Is she still here? For the most part, I believe they are independent from Medicaid. They're an independent working body providing recommendations to the Medicaid program. Next question. Do we anticipate transparency in the review process will improve the medical benefits side given all of the biologics coming out on the physician administered side? I mentioned this briefly in that if we're talking about the biologic products that are coming out, we've seen more and more states include physician administered drugs as part of their PDL process. We've seen more and more states bring physician administered drugs to their DUR boards and P&T committees. And so in that sense, that we are seeing more transparency in that. The typical process in the past has been pretty much behind the scenes, a lot of internal reviews, a lot of internal decision making. That's why the relationship between you as a manufacturer and the state has always been so important. But we have seen a lot more of these drugs coming to these public entities and these public reviews and giving you more opportunity to see the transparency in the process. So I hope that answers your question. Next question. Are there issues with cost shifting between prescription MX, I'm not sure what the MX stands for, benefits or medical benefit, I guess, when the state carves out drug, i.e. managed Medicaid making provider administered drugs to pharmacy only benefit? Eric, you want to take that one?
Yeah, I think this is referring to whether, if there is a carve out, are the managed Medicaids moving drugs between one of the benefits to try to get that removed from their responsibility. And it can have an impact there. And I think we started to consider this for California because they're going to that pharmacy carve-out model. And there are certain clients of ours who have drugs that are launching that could be considered medical benefit or pharmacy benefit drugs. And maybe with the way California is going, the managed Medicaids would prefer to cover them as pharmacy benefit drugs so that they would be relieved of having to pay for them. So there is some political and financial maneuvering that goes on, but there is always a discussion and an open line of communication between the state and the managed Medicaid plans. So most of these things are hashed out behind the scenes and agreed to by the state and the managed Medicaid plans, but probably not before some amount of debate.
All right, thanks, Eric. We got time for one more question from Slido, and then what we're going to do is we're going to catalog the remaining questions associated with that. I want to get you guys all out on time. I know everybody's eager to get to the tin roof. So last question here, Greg. P&T committees often conclude that there is no clinical differentiation between products. When H2H data shows superiority, are there ways to challenge this? So we encourage all of our clients and manufacturers to maintain that great relationship between you and the state so that you can get in and discuss the clinical benefits of your product. And not only do you want to do that with the state, you also want to do that with those PDL vendors, such as managed Medicaid plans, such as Magellan Medicaid, Change Healthcare, etc. So is there a way to specifically challenge this? I can't tell you that there is a silver bullet for that. All I can tell you that is you have to come in with a very clear, concise, clinical value statement of your product. And it could, maybe it's not necessarily the clinical piece that is hindering that decision from the state's perspective. Remember, they always make the decision not only on the clinical component, but also the financial component. There might be a very big financial implication to the state. And also just remember that in many cases, non-preferred may not necessarily be as bad as you think. It depends on the drug, it depends on the class.
Yeah,
you have anything you want to add to that?
I would add that you should always see if there is a KOL willing to make your case or make the case for a specific patient who has been denied with medically inappropriate data. And the arguments that a KOL makes, again, I'll keep saying this, go a lot farther when they're talking directly to a payer than when you're talking to a payer. And I'm not disparaging you or us, but the KOLs and the providers who are actually treating Medicaid patients, their comments go a long way.
Thank you, Eric. So can we flip back to the slide deck so we can give these folks their CE information? There we go. So while you're copying down your CE information, just want to thank everyone for joining us. If you have any questions, any additional questions, again, we're going to catalog everything we found in Slido. Also, feel free to reach out to us. For those of you still on the phone or on virtual attendees, a PDF of the presentation is available for download on our virtual platform under the Agenda and Materials page. For all of you who are here in person, you will receive access to the platform on Thursday. This recording will also be available on the platform on Monday, July the 19th. So lastly, our opening party will begin tonight at 6 p.m. at Tin Roof in downtown Nashville. Shuttles to and from Tin Roof and the JW will begin at 5:30. So you have about 30 minutes for the shuttles to begin, taking you to Tin Roof. We've got a band that's there. We hope to provide great entertainment. We have lots of great Southern food, a rooftop with a great view of Broadway Street, 2 full open bars. I know you're probably going to need a shot after this today. All right. So we hope to see you all there. I want to thank all of you for attending Medicaid 101. I know it's a lot of material. I want to thank our sponsor, AbbVie, for Medicaid 101. And we will wrap this up and see you all at Tin Roof. Thank you very much.